University of Southampton.
Thank you very much indeed.
I'm Sue White. I'm Professor of Social Work at the University of Sheffield.
Can you make sure you speak up? Just
Sorry,
so we can, yeah,
that's
sorry.
normally
There's
something
quite a lot
I
of
have to
movement going on
worry
behind
about.
you.
Yes, did everybody hear that? Who I am, yes.
I think so, yeah, good.
Hello, I'm Mark Bellis. I'm Director of Policy Research and International Development at Public Health Wales and Professor of Public Health at Bangor University.
I'm Eamon McCrory, Professor of Developmental Neuroscience and Psychopathology at UCL and also consultant clinical psychologist with expertise in working with maltreated children.
Brilliant. So we'll all be asking questions. Don't feel, where there are questions to all of you, don't feel you all have to respond if you don't feel you've got anything specific to add, because we've obviously got quite a lot to get through. I wanted to start by addressing some questions directly to Professor Bellis, if I may. So, Mark, could you briefly outline the evidence-based linking adverse childhood experiences to negative impacts later in life? If others want to add on to this, please come in as well. So, could you start with that, please?
Certainly. There's now a series of studies, both retrospective, so asking people now about what happened to them in the past and linking it to their health conditions now, and prospective, so looking at cohorts that have been studied so we understand what happened to them in terms of abuse, neglect, exposure to domestic violence, alcohol, mental health problems and incarceration, incarcerated family member in the household, and then looking forward across their lives and see what their health outcomes were. There are considerable increased risks associated with those adverse experiences in childhood. If you take things like alcohol problems, then often they can be 5 or 6 times the risk in later life that people will have a problem with alcohol. They also have much more difficult problems with criminal justice in terms of risks, but also some of the health outcomes that people may not necessarily link with what happens to you as a child, things like risks of cancer, cardiovascular disease, and some of the things which are implicated in that, as well as alcohol, higher levels of smoking, problems with diets, and in fact the first day studies were looking at things around diet and problems with weight. As well as those associative risks, we are increasingly getting biological markers, so people are looking at people who've had adversities as a child, and whether that's affected some of the markers which we would expect to see if they were developing, often as I describe as a heightened state of alert. The body is expecting trauma because that's the way they've experienced as a child, and if your body's at a heightened state of alert, it wears out more quickly. So things like immunological markers are higher, ones which are associated with things like diabetes, things like cardiovascular disease, some of the proteins the liver develops which are associated with those sorts of outcomes as well, and even some of our markers of how fast cells age are also higher and worse in children who've had these adversities in childhood. So I know the time, so is that...
Yeah, that's helpful, thank you. Now, the witnesses will all have their opportunity to give their particular perspective, but are there any brief comments on what we've just heard from Mark?
I think we'll just wait.
Happy to come back to it. Okay, yeah. Thank you. So, Mark, again, what criteria are used to decide what constitutes an ACE and what doesn't?
Most people probably use a list of ACEs which have been described jointly by the Centers for Disease Control in Atlanta and the World Health Organization. There is a list which varies, but they typically include things like abuse and neglect as a child. That can be physical abuse or verbal abuse. It can be emotional neglect, and it can be physical neglect, so withdrawing support from a child or not providing something that could otherwise be provided. And then there's a range of factors, as well as sexual abuse, as well as another I should have mentioned, which happen typically in the childhood environment. Things like exposure to domestic violence, living with someone who's got some severe mental health problems, or an addiction to alcohol or drugs.
How do we deal with the problem that a particular adverse experience may be much more significant in one case than in another case?
Yeah. So there are a couple of factors around that. First of all, It may well be true that one is more problematic than another. But of course that may depend on circumstances. So if you took physical abuse and verbal abuse, somebody might say that physical abuse was worse. But if physical abuse was suffered once every month or so and verbal abuse was every day, then that may change things as well. Another thing to bear in mind is that these things often co-occur, more often than you'd expect. So it's not a random mix. So people exposed to physical abuse are more often than not exposed to verbal abuse. They may live in a family more frequently with domestic violence. And that's one of the difficulties in disentangling them, but in part one of the benefits of looking at them together at the total level of ACEs that people experience, because that gives us a good and predictive measure of many of the poor health outcomes that people suffer across their life.
It's often said that the evidence points to an increased number of adverse experiences results in increased harm later on, and yet do you also accept that a single adverse experience, a sexual attack, for example, could in itself be much more significant than 4 lesser traumas? Does that make sense?
Yes, it does. And there's a distinction between what often I'm involved in, which is epidemiological studies, where you're looking at factors on average. So, for instance, we count as an ACE any sexual abuse, no matter how often it counts. It happens as a child. And it may well be that some of those things are having a much bigger impact in some people's lives, and the combinations will be different in others. However, as a tool to describe on average what's happening to people who are exposed to certain things and their increased risks of certain outcomes later in life, it works relatively well. When you're dealing with things on a clinical basis, of course, people want to drill down into the details.
And why is socioeconomic status not part of the mix? Because I would imagine that a lot of the identified adverse experiences are related to socioeconomic status in one way or another. So why is that not identified in itself as a significant factor?
In some papers, socioeconomic status is included, and that's in the mix with ACEs. In many of them, many of the pieces that I've been involved with, but other ones, most commonly, certainly, I think in the reviews we've done, socioeconomic status is included as a separate factor. In other words, you include ACEs and socioeconomic status in the models that are trying to explain what's happening to people. Typically, you get independent effects of both. So you find out that there is a problem related specifically to socioeconomic status in early life, but actually with ACEs, it doesn't matter if you are exposed to those ACEs. If you were poor or you were wealthy, your outcome is worse in life than if you weren't exposed to those ACEs.
Now, you talked about the non-health impacts in terms of, for example, employment, education attainment, criminal justice system, but are they byproducts of health impacts? In other words, if you suffer from mental health issues or physical health issues, they have knock-on effects in other non-health related areas?
There seems to be a combination of direct effects from ACEs and indirect. So, of course, one of the things we're actually looking at the moment would be employment, and whether that is, exactly as described, mediated entirely by your poor uptake of education and difficulty concentrating, which often you get with these outcomes with ACEs in classrooms. Yeah. There seems to be an effect of both. There is an effect related through educational performance, but there's an independent effect as well about those changes which are happening to people, which may also give them problems in terms of holding down a job, being able to engage in order to get a job in the first place, which may not just be about the educational success they have.
Now, what are the benefits and also the downsides of considering the basket of experiences together rather than looking at individual adverse experiences?
One of the key benefits is that it creates a field of interest across the public sector, and that may be in terms of a policy element, but it is because everybody can see their role in addressing ACEs: criminal justice, education, social, health, and they're looking at a basket of things which people both understand what bits they might be able to tackle as part of reducing the ACE load that people are carrying, but also the benefits that they can see in terms of what they're trying to do themselves. So reducing those ACEs may well increase educational outcomes, but at the same time it might reduce the level of criminal problems. So you're getting benefits across the piece by addressing that lot together. The other thing is by looking at them together, that you don't, I agree, disentangle all of them, but you are looking at a measure of the total number of problems that often people experience. And for many people, that might be a more realistic way of looking at it, because these things don't happen often individually.
Okay. Now, before I bring in Bill, can I just ask whether any of you want to contribute on what we've heard so far? Yes, Ros.
Yeah, I'd just like to sort of talk about the bringing together of a whole load of different things, because it might be sort of very useful for establishing a field of intervention that lots of people could key into, but actually methodologically, in terms of actually trying to identify issues and their effects and so on, it's a chaotic concept. It's sort of conflating a lot of issues together so that you can't place much in the way of explanatory weight on them because of that. Because I think, as you drew attention to, we don't know about severity, we don't know about timing, we don't know about duration. And so it assumes that they all work in the same way and they have this end state. And we have to be very careful methodologically in talking about associations and correlations, rather, the causes, which is the explanatory thing. And I just to sort of broaden out a little bit of background in terms of the context into which this enters, is that bad things happening to children that are bad are bad. We don't want that to happen, and we try and look for ways to prevent that. But we live in a very complex and dynamic social world, and it means to say that because of that, evidence is often uncertain, it's qualified, it's provisional, and so on. It's often difficult to replicate studies for various reasons. But another thing to take into account is that, in which I'm sure my academic colleagues will speak to as well, is that we have a publication bias. So what gets published are positive results. It's very difficult to get negative, null results published.
We're doing another inquiry on that.
Yeah. But that means to say that when you gather together evidence, you're gathering together a certain biased set of evidence, if you like.
Thank you. Sue, did you want to?
Yes, there are a number of things. One, I think Mark has very eloquently talked about the public health angle on this, and one can see when you're trying to make decisions about resourcing and so on that this is a useful acronym. However, it's powerful because it's been created to be powerful. It's been designed to be powerful, to persuade people like you and others that this is something that is worthy of investment by the state and activity. But it's not entirely straightforwardly a good thing, in the sense that it does conflate a range of things which I'm sure Eamon's going to talk about later, which might be considered to be a kind of clinical population or very at-risk population with documented histories of things that we, as a social worker, would call abuse of one sort or another. A lot of the things that are in this ACE category, which I'm sure people, when they're talking about it, will try and disambiguate, but there are a very, very wide range of life experiences that are in there. And because we have access to technological biology and neural brain imagery and so on, they are tending to be written in terms of biological scars in various sorts. Now that's all fine if you think you can get in really early and stop all this. It's not a particularly hopeful and helpful story for young people or indeed adults who have already had ACEs. So that needs to be
But that's not a
thought
reason
about.
not to seek to find ways of addressing the problem and preventing things becoming entrenched, is it?
No, it's not a reason to stop looking for those things, but it's an unintended consequence of all the cards are ACEs at the moment. Everywhere I go, everybody is talking about ACEs. And often in very helpful ways about building resilience, about having careful conversations with children in schools, in the criminal justice system. I think probably they could have had those conversations without the concept, but if it helps, then that's a good thing. But the other thing is the level of explanation, and I don't have any problem with anything that Mark has said, and it's not particularly surprising to me that there are these outcomes, having worked in the child protection system for 35 years. But there is, it's your question from before, there is a very, very complex relationship between these kinds of intrafamilial activities and social deprivation. One doesn't straightforwardly cause the other, but there is a relationship. And it's, I mean, the ACEs 4+, there's problems with counting them as well, but we'll leave that for now. The more than 4 ACEs is more strongly correlated with social deprivation. Now, you can leave it like that and say, actually, it's all very mixed up and it's something to do with ACEs and social deprivation, or you can hold one or the other more responsible. There's more ACEs because people really struggle in complicated, socially deprived circumstances to parent, they don't have support networks and so on. So actually we'll deal with the community-based resources that communities and families have. Or you can say it's not social deprivation, people are socially deprived because they had ACEs, and it's an intergenerational cycle of ACEs that's causing it. Now that decision, what you do about that explanation, that thorny, absolutely tangled mess of explanation, is a moral thing. Do you deal with the ACEs, and or do you deal with people's material circumstances? So I'm just trying to...
But it doesn't have to be, your and or is key, isn't it? It doesn't have to be one or the other.
It doesn't have to be one or the other, but the way I'm watching the narratives go...
Am I right in characterising your position that, not to reject this, but to say, be careful, don't make assumptions, and pursue more evidence, secure more evidence before you reach fixed and firm views on it? Is that?
Yeah, and be careful what stories you tell to people, because they have an effect. But just one final point, and then I will shut up. There's a problem with net widening in terms of the system pulling more and more children into it that the system then can't cope with. And that's what's happened with children's social care for years and years and years. And what happens is people try and gate crash into the system because they're worried about children, and social care tries to keep them out by gatekeeping, and the thresholds get higher and children get less safe. So that's just another possible unintended consequence if it's not handled with a little bit more sobriety in place.
Eamon.
I'll try and be brief. I would support what the other panellists have said. I think it's important for the committee to remember that it's simply one explanatory model. It's one tool that researchers have developed to try and capture longitudinal impact of early experience. I would see ACEs as having a number of advantages and disadvantages. I think one of the really powerful aspects of Mark's work and others has been to demonstrate that many adult mental and physical illnesses are developmental problems. They have their roots in childhood, and that, I think, has been incredibly helpful in shifting people's understanding of where substance abuse problems come from, depression, schizophrenia. These things have their roots in early experience. And it has helped galvanise, I think, a societal conversation about the need to think about investing in early care and support and resources for vulnerable children. But there are a number of disadvantages, and I think they've already been articulated, and I think you've noted them yourself, that not all adversities are the same. So my own work, as you said, focuses on children who've got documented experiences of maltreatment and abuse of a sufficient level of severity that brings them to attention to social services. And we know that maltreatment and having a parent with a severe mental health problem are within the ACE categories significant predictors of later outcome. So not all adversities are the same. Another difficulty with ACEs, as someone who tries to understand developmental mechanisms, is that they really obscure the way in which these early adversities might unfold over time to lead to a problem in adulthood. So having a parent who divorces, being caught up in a hurricane, or experiencing severe sexual abuse are going to have very different underlying mechanisms in terms of how they impact later development. And finally, I would say that there is this question about the total number of ACEs is likely to be confounded by severity. So as Mark says, these things generally co-occur. If you've got a high ACE score, it's probably more likely that you will have a high level of severity of the ACEs you have experienced. So I think within an epidemiological framework, it can be incredibly helpful. I do agree that taking that then to a clinical context as some kind of tool, or trying to have a conversation with individuals about ACE scores, I think is problematic. And as a clinician, I personally don't think it is helpful to bring that kind of number into a complex set of experiences that an individual might have had.
Thank you very much, Bill. Thank you, Jim.
Just generally to the panel, are there any particular areas where the evidence of correlation between ACEs or adverse experiences and negative impacts, where it's still uncertain? Is there any particular specific areas where that correlation is still unclear or uncertain?
I'd say it's all unclear. Because we've got we have such different definitions of what is ACEs. We have, they're very based on the child-parent situation, but they're more and more are being pulled in. So disabled mother was one that I've seen that's been added into that, or sort of moving home. All of these things get pulled in. So you've got this sort of basket of definitions, all different definitions. Then you've got no certainty between studies. You might have within a study, but no certainty between studies as to what the timing or severity or whatever it is. You've got different methods for studying them, retrospective, prospective, experimental, and so on. And then you've got all this rush of outcomes that you look at, and you just don't know what's going on there.
You'd be led to believe almost by the level of things we don't know that there's nothing in there worth knowing. The reality is that actually the results across countries and populations are remarkably consistent. And what they tell us across most mental, physical outcomes, criminal justice outcomes, is we're seeing consistent results from the numbers of ACEs that people are exposed to in different countries. Of course, as I said, it doesn't give us a clinical insight into an individual, but it does give us an insight into the fact that people's life courses are heading in the wrong direction, in part because of things that happened to them earlier in life. And I think the evidence on that is cumulative and it's consistent.
And I would just add that I think Mark's recent paper in The Lancet demonstrates that there are differential associations. So there's weak evidence, for example, in relation to obesity, but stronger evidence, for example, in relation to mental health as possible outcomes.
This question a wee bit further, and I'm noting the three phrases, all unclear. Somebody said not a good thing, and somebody said chaotic concept. So I'm going to ask, is there a sufficient body and diversity of evidence to overcome any methodological challenges in some of the studies? In other words, where a study may not be overly confident in the methodologies used, can that be compensated by other evidences? Is there a compensatory factor?
I kind of struggle with these questions about the evidence base, because in a sense it's sort of obvious that adversity in childhood is a bad thing. We've had a vocabulary to describe this for a very long time. It's just that it's now it's been turned into a concept for very good intentions to try and draw attention to adverse experiences. Not a lot of mention of adverse environments, not as much as you would expect. And a heavy focus on intrafamilial stresses of various sorts. So not, for example, focusing on how scary it is living in a particularly scary place with lots of violent crime, or something that is nothing to do with your parenting. and it's stressful for your parents, and it's stressful for you. So it's a concept that does particular things. I mean, I don't find it remotely surprising that there are strong correlations between childhood adversity and mental health problems. But you've also got to remember that this is backwards reasoning. There are lots of people who will have these experiences who, for various points to do with their own resilience, their own biological makeup, whatever it is, are fine-ish. You know, they can tell a story about it, they can make sense of it, they have perfectly fulfilled lives. So taking a clinical population and finding an overrepresentation of children with adverse experiences is totally unsurprising. It's interesting scientifically, but it's not surprising.
Should be trying to do something to reduce the impact.
Yeah, and that's the thing. What?
Yeah, sure.
I think you may have answered my next question, which is directed not primarily, but not exclusively, to Professors Edwards and White. In your written submission, I think you intimated it fell somewhere between criticism and advising caution of the methodologies used, and have found the correlation between ACE and problems in later life. Do you contend that the exposure to poor or bad childhood experiences is not necessarily linked to problems in later life? Is that you're suggesting that?
I think
It's
everyone
not,
would agree with that.
yeah.
It's not a deterministic relationship, it's a probabilistic relationship, and the IS methodology is based on that.
And there are protective factors we are starting to understand, such as drawing resilience from having another stable person you can turn to, or being well embedded and supported within the community from other sources, which provide some support, particularly for those people who are suffering more ACEs in the home environment.
But I think it was suggested earlier that the people who have maybe suffered 4 or more ACEs in the home environment progress through life due to, I think you said, through their own resilience or other sets of circumstances, they find their way. So they're not necessarily constrained by ACE experiences.
Yeah, and a lot of people get quite angry about
suggest,
it's not the deterministic tone, that we're not hearing it here, but certainly in some of the training materials there is a terribly fatalistic, deterministic tone to them. You know, my doctor tells me that my brain is damaged, says the cartoon little boy. It's not useful for young people who have had those experiences to have that kind of story told to them.
Suggesting you could be inadvertently drawn into this system where they'd actually possibly escape from it.
Well, it could be a self-fulfilling prophecy. It's a quaint, rather old-fashioned sociological concept with no brain imagery, but it actually is important that if people are told that they are damaged, then they're going to have lower expectations of themselves.
And yet there is also... Is there not a danger... sorry, Bill, there is a danger, is there not, that, I mean, for instance, a child who perhaps has suffered sexual abuse, if it's not explored or identified and nothing's done about it, then, as I understand it, it emerges in later life potentially as a diagnosis of personality disorder or a psychosis. Or so not doing anything is not the answer, is it?
I think people having sensitive conversations and what we used to call taking a decent social history when people actually are struggling is absolutely the right thing to do. I think paying attention to building sources of resilience in communities, between families, and there are ways of working in community mobilisation type ways which for a lot of children would make life better, even if you can't do anything about the circumstances that they're living in and the families that they're living in. So it's, yes, being sensitive to the possibility that there has been a traumatic, genuinely traumatic experience, because trauma is also being flung around all over the place, but something that has really, really traumatised a child and produces a susceptibility to problems in later life. Absolutely right. Again, the ACEs concept might have sensitised people in the system to that a little bit. It might have over-sensitised people in the system to it, and that's the thing that's going to be really difficult.
Bill, sorry.
Are there problems with imprecise definitions of ACEs? And also, in parallel to that, are there maybe inaccurate returns or evidences when you ask someone to self-assess, somebody at a relatively young age, to self-assess their adverse childhood experiences? maybe not overly young age, but is there risks associated with
Yes,
self-assessment?
So if you do a retrospective study, the ACEs come out as higher than if you're just looking at a cohort. Some of our excellent cohort longitudinal studies, they're lower, the prevalence in the population. So people may overestimate, they may underestimate as well, but they're just, looking at it methodologically, you have to take account of the fact that they may overestimate as much as they might underestimate in retrospective accounts or in its self-assessment.
But notwithstanding those limitations, the evidence from prospective and retrospective studies is unequivocal that extreme forms of childhood maltreatment, so sexual, physical, emotional abuse and neglect, have demonstrable impact on outcome in adulthood.
The problem is that ACEs are all
so this
those things.
is why it's important for the committee not, I think, to get too hung up on ACEs, because of course childhood maltreatment is important and deserves important scrutiny, and that's not the same as having parents who divorce. This is so I think it's been a helpful tool to look at a broad range of co-occurring risk factors from an epidemiological point of view, but that's quite different from thinking then about policy and practice at an individual level. And I think we could all agree on that.
Yeah, I think the absolutely retrospective and prospective and those sorts of methodological issues, they broadly come out with the same results. So it's not a problem with how people are being asked. The other thing to bear in mind is we shouldn't really make assumptions
Could
about
I just check on that one, Mark? That you don't feel there's an issue with self-assessment. You're comfortable with the assessment result?
There's an issue in both directions. People retrospectively may forget the odd thing. That's true. Prospectively, people may not want to tell you at that time, or parents may not want their child to disclose. So in both directions you can get underestimates. But there are good pieces of work out there that have looked at what happened at the time and what people remember in the future, and they correlate reasonably well. The other very quick point I think I should make is we shouldn't make assumptions about what people with ACEs think about what's being discussed about those, because it's very easy to do that. For instance, people mentioned a little video there. Well, fortunately that little cartoon was tested out on people with ACEs. They liked it more than people without ACEs. So it's easy to make assumptions about how these things were received. The other thing to bear in mind is that most people we talk to ACEs about, or other people, they've never had an opportunity to talk about those things at all. So there's a question at some level about leaving these things entirely unaddressed, or recognising this tells us something about something that needs to be done early on in life, and identifying exactly what those interventions are.
And finally, we're pleased to know one for yourself, Matt, that the others can come in. In Wales, there was a study done with a pool of 2,500, I think, individuals. Yes. In your experience, are you comfortable that was a sufficiently large number to be confident in the outcomes?
Yes, and we've actually repeated that study. So we've got more people. The results are consistent with the first wave, and a similar size study, a larger study, actually was undertaken in England. And the results are reasonably consistent across that piece as well.
Common denominator, different areas?
Similar, not identical, but you wouldn't expect that, but similar levels of ACEs, very similar levels of outcomes in the medium term in terms of health harming behaviour, smoking, drinking, and longer term in terms of some
of the both relatively small samples?
The total sample available across England and Wales now is probably from those, just only those sorts of studies, is about 14 to 16,000. Right. But there's also birth cohort studies which have followed people through life available in the UK as well, and they find similar results.
Thank you very much. Thanks very much, Chair.
Thank you.
Thank you, Chair. I wonder if I could just explore a little bit more the question of causation rather than correlations, because we've jumped around a bit between the two so far. Firstly, can you talk a little bit about how we think what the causal mechanism is between linking ACEs and adverse outcomes later in life? Obviously all the ACEs don't work in the same way. Can you tell us a little bit about what the different causal links might be? And secondly, how satisfied are you in terms of the evidence base about your ability to control for confounding factors like socioeconomic status, because of course all bad things tend to go together, and how confident are we can control for that and pull other effects out of that when you're talking about causation?
I'm happy to answer in relation to childhood maltreatment, so physical, sexual abuse and neglect, exposure to domestic violence. I would first of all say that we know very little about pure causation. I think our understanding of the developmental mechanisms remain limited. So my work has really focused on trying to look at the neurobiological impact and social and psychological impact of early adversity and maltreatment in particular. And what we have found is that maltreatment leads to a set of structural and functional changes in the brain. And contrary to kind of previous narratives, which I entirely agree have been unhelpful, these, we believe, are not reflective of damage, but rather reflecting that children are adapting to live in chaotic, neglectful home environments where they need to survive, they need to regulate, they need to cope, they need to find a way to survive in those very atypical early environments. But those adaptations at the neural level then become maladaptive when the child goes into a normative school context or a safe foster placement. And our understanding of what we're calling latent vulnerability in terms of causation is that there can be, as Mark says, both direct and indirect effects. So if you imagine a child experiencing domestic violence and physical abuse in a family home, they may become hypervigilant to threat in their environment. We know that can lead to allocation of attentional resources to threat cues in the environment, even at the subliminal level, and so they have less resources to attend to typical social educational tasks. So that can have an indirect effect, but a direct effect, but there can be indirect effects over time. If you have a heightened hypervigilance to threat, you're more likely to have a hostile attribution bias. Your interactions are more likely to be conflictual. You can imagine how that might play out for a child in the school where they're getting into more fights with peers. They may end up being excluded from school, and that can have long-term effects on their economic productivity. But more importantly, I think, is that the adaptations can actually make it more difficult for the child to elicit, cultivate and sustain the kind of protective relationships that can help buffer them from future problems. So our idea of causation is that children adapt in these early environments to survive, but those adaptations become maladaptive, and particularly in relation to being able to access and make use of factors that could actually promote resilience. So it's almost a double hit, because the very things that could help them become more difficult to access. So we know that these children find it difficult to trust others. They are in constant placement changes. They have a constant turnover of social workers. So they find it difficult to actually make use of protective relationships that could actually help promote a resilient outcome. So I would say that that's the theory. That's a theory that hasn't been tested because we really lack in this field robust longitudinal studies that follow up children with documented experiences of abuse and neglect. There are a number that in terms of an epidemiological level, which are very general, but in terms of mechanism, you need much more precise kind of ways of measuring how a child is processing the world. And we're conducting a longitudinal study currently. There are one or two others in the States, but our evidence remains limited, and we're really trying to test a model of how we think vulnerability might be embedded following these early experiences and how they might unfold over time. And a longitudinal frame is essential in order to really clarify that.
Thank you.
I'd agree with all of that. I'd add that it's not just relationships with individuals. Some of the work we're looking at the moment means that they're less trusting of services that are available to support people for similar reasons. And the evidence, although longitudinal studies, of course, the more we get, the better, but it is still consistent with that idea that the brain is developing for a different set of circumstances. The tools needed to the brain are ones which are expecting them for trauma, but equally other parts of the body are responding in similar ways, so the immune system and other parts which are preparing a child for a more traumatic life. That may well be an adaptive advantage in that situation, but it means that certain systems are going to wear out quicker. It means that when people look at people, they're less trusting and seeing a neutral face as a hostile face, and those sorts of things then limit life chances and also cause long-term heart and health problems later on in life.
And just very briefly, just before Sue responds, I mean, I would just want to emphasise again the importance of a narrative being about adaptation rather than damage, which I think is pejorative, and also about a relationship that's probabilistic and not deterministic, because ensuring a sense of agency is really important. And I think there has been some work that has unhelpfully created a narrative around determinism and damage, and our work, and I think Marx and others have really sought to shift the focus much more on adaptation and a probabilistic relationship.
Yeah, I agree with that. The problem I'm having with the ACEs thing, which I've said before, is that Eamon's just been talking about children who have been abused. Which, you know, as I say, I've worked in the child protection system a long time. Children do get abused and go through some terrible things. And the clue's in the title, abuse. You know, it's abuse, it's harm. The problem with this concept, not necessarily in its design, but in its operation in the child protection, the general child welfare system, is it is in danger of stretching the category of what are harmful experiences and where the state can tread in order to ameliorate those. That is something that we can have a debate about as a society, but what you don't want is a kind of form of function creep where everything becomes an ACE and it becomes more and more problematic for people to make different choices about how they parent their children, because everything that we don't necessarily approve of is not abuse. And is the human organism is actually pretty resilient. So probably a lot of people are experiencing a whole range of different life experiences, and it might be affecting their biology. Might be, if you look, you'll probably find something, but it's not affecting their functioning. It's not affecting that. So we've got to be careful about producing this fatalistic, pessimistic narrative about children. We can't possibly be more traumatised than any other previous generation. It's just not plausible. So something's going on culturally about the concentration on intrafamilial harm. And it's in a context where there are lots of other harms, which are also affecting other members of the family, mothers, fathers, siblings, all sorts of things. So this is not a criticism of the ACE concept, which is doing a particular thing in a public health context. It's a cautionary note about what happens to these things when they get out there and what kinds of expectations become set up about what the health service, schools, whatever should do, and when families can say no. And we've got the debate about the named person in Scotland, which is rehearsing similar things.
Just to say that, of course, you know, totally accept what Eamon is saying, and in fact, it's not just children who suffer abuse whose brains adapt. You know, our brains adapt. Yeah,
well,
everybody's brain
do. I think.
Yeah, everybody's brain adapts, and so it'd be really wonderful to put children who have been brought up in, and young people who've been brought up in really affluent, privileged circumstances into the fMRI scanner and see what their brains look like. Are they more prone to taking risks with other people's lives and money and so on? So it's not that these people are different. They are doing it's a biological process that we all go through.
Eamon's description.
No, I'm saying that all brains adapt, as he said. So
but sometimes with damaging consequences, I think is.
I think the distinction is that brains adapt in very specific ways that can give us important clues as to why vulnerability becomes embedded in the longer term. That's why we do this research. I can entirely agree that all of our brains adapt to all of the experiences that we have in our lives. That's what brains are there for. It's a learning organ. But the neuroscience of early adversity is there to help us understand the mechanisms whereby this may play out as a vulnerability factor.
And they're particularly adaptive in the early years. I mean, that's worth bearing in mind. These are critical formative stages, which as we understand more and more about that. So it may be that the brains are adaptive, but certain things can be laid down in these early stages, which then it's more difficult to overcome.
So I think Sue and Rosalind are absolutely right to raise the concern about the huge remit that ACEs have. But I think that the advantage of something like ACEs, but I'm not saying ACEs, but there has been a problem in the field where people study maltreatment like me, other people study bullying, other people study the impact of parents' mental health problems. There has been a problem that these different domains, which are all relevant to later outcome, have been studied in a silo-based system. And there is a way in which it will be important to bring together the range of early adversities that we think may affect development over time, and bring those together in thinking about causal mechanisms.
Neil.
To that point, this is mainly a question for Eamon, but I'd be interested in others' views, which is how good is the evidence that ACs can cause significant changes in brain structure and function? So your first answer was in the language of psychology or psychiatry, of maladaptation to a hostile environment, but rather than a kind of biological, neurological one. And obviously there are some famous examples of sort of pop science in this area where people show you an image of a brain scan of a Romanian orphan who's a really incredibly extreme example of these things. But when you actually look at the brain, the neurobiology of it, how do you go about measuring these changes, which obviously are real things psychologically? What are you measuring? Is it dopamine? Is it what? Are you able to? What are you looking at on the MRI scanner? And could you ever use any of these things as a diagnostic test? Could you say, these two children have been exposed to this terrible abuse? Looking at this child's brain, they have been more profoundly affected by it, and we should be more worried about them. This perhaps sort of speculative, but if you could talk to those kind of questions.
So I think the picture of the Romanian orphan is where some of this difficulty arose, because that was a child who we don't actually know who they were, but we presume that they experienced severe emotional abuse, neglect and deprivation, and some of the damage could have been physical due to malnutrition. Sensory deprivation. So the degree to which those early studies were relevant to thinking about children in this country, I think, was very limited. In the last 5 or 10 years, there now have been a significant number of studies that have recruited children from North America, from the UK, who have got documented experiences of abuse and neglect. And fMRI and MRI have been used to look at structural and functional brain differences. So we know that in terms of brain structure, there are changes in areas involved in learning and memory, such as the hippocampus, and the frontal cortex, which is involved in behavioural and emotional regulation. So people have looked at differences in terms of volume and in terms of cortical thickness as markers of difference relative to peers. All of our work we match for peers matched on socioeconomic status, age, IQ. So we're pretty confident that these are differences that are related to the experience of maltreatment. And we also then have fMRI that looks at functional activity, so we can see how does a child process the world. How do they process the cue related to threat? How do they process reward? Our recent work has focused on autobiographical memory functioning. I think it's really important to think it's not all about threat vigilance. So how a child thinks about their own past, we see profound differences in the scanner in relation to how they think about everyday positive and negative memories that is strikingly similar to what you see in adults with depression, essentially. And so this is where we combine the psychological and the neurobiological. So the bit of the brain involved in memory specification is much more active for negative memories than positive memories in these kids. And memory specification is much more active for negative memories. And they also have a more activation of a salience network when they recall negative memories. So they seem to privilege negative memories over positive memories, and that's the pattern that you see in adults with depression. And so neuroscience, for me, has been helpful because that has prompted us to do a new set of behavioural studies to explore the way in which a child might have developed a different memory processing style that could lead to more rumination and more risk of depression later on. And we're following these children up longitudinally.
That's a question about sort of how fuzzy is this to use this sort of diagnostic tool as a way of thinking about it?
Yeah.
The correlation is incredibly fuzzy when you look at it?
I think brain science, we do not need brain science to carry out diagnoses. We know these children have experienced abuse and neglect. brain science generally to diagnose a clinical disorder is not very reliable. These findings are on a group level, they're not on an individual level. But what we are using the brain science to do is to identify areas that could be developed into psychological tools that could be helpful in clinical screening. So the NSPCC have funded a study which is looking at short computerized tasks that have been based on the neuroscience evidence, games that children play to see, well, how significantly did they adapt to the early environment in their threat vigilance or their autobiographical memory functioning. And that could be one way to kind of index their underlying vulnerability. So that's a medium to long-term ambition. Can we find ways to identify those children who are most vulnerable through a routine clinical screening tool? And it's not the neuroscience, but the neuroscience is the kind of the theoretical, empirical driver to develop those tools. But whether they're actually going to be psychometrically valid, whether they're going to be predictive in practice, is just an empirical question. We're doing the study now. We can tell you in 4 years' time.
Just one thing really, because again it's this problem with the kind of the clinical task, trying to understand as a clinician what the neurobiological structures and functions are that underlie a child who is presenting with emotional or behavioural difficulties or is particularly at risk of them. But in terms of developing a policy to help people, let's just move away exclusively from children, because they do live with adults as well. So if we're talking about building resilience in communities and families, would these experiences be okay if there were no biological damage to the children?
Of course they would not be, but the point of the neuroscience is not to provide another level of evidence that this is a bad thing, although for some people that actually has been necessary to realise emotional abuse is serious. The neuroscience is there to provide our understanding of the underlying mechanisms that we simply currently do not understand. And if we don't understand the mechanisms by which disorders unfold, we're in a very limited place to develop preventative models of health.
Can I put one just last proposition to you, see if you agree? Could you imagine a future in which people who had experienced abuse, you might use the neuroscience to suggest, in a sense, different types of treatment? Is that a possibility?
So people are using that in terms of trying to think about best treatments for depression, best treatments for anxiety disorder. I think we're a very long way from that. I think it's a possibility. My experience is that most children who experience abuse and neglect, the problem is they receive no support or help of any kind. So this is just sort of an arbitrary question. They wait until they have significant clinical problems and they refer to CAMs who feel they can't help them because the problems are so complex. I mean, at the moment, there's very little preventative work to actually help these children at that early stage before problems have evolved.
Can I just make a plea? This is an absolutely fascinating discussion, but you're all talking for England. And we are...
or Northern Ireland, I have to point out.
Ireland. And we are horribly over time. And so can I please just make a plea to try and keep your answers as tight as possible. Now, Mark and then Vicky quickly, and then I'll bring in Martin.
Just very quick. Much of from the public health perspective, the issue about ACEs is de-escalation, non-escalation. It's about what support. Multiple people are suffering different levels of ACEs. It's about what support, what can be avoided because parents understand that the impact it will have. It's about what support communities can give, and that isn't. Of course, there's the heavy end when there's some real severe things happening, but much can be done if people just understand that lower level intervention that can be delivered not necessarily by some highly trained professionals, but by people contacting these children every day, can avert some of the more longer term problems.
I find this all quite challenging because I find it challenging the suggestion that just because somebody's had an ACE that could lead to their brain developing in a different way. I think you need to be really careful about that causality.
No, there's not. It's not causality. It's no need to be careful. It's a fact. If you learn how to play the piano, your brain changes. If you learn a new language, your brain changes. And if you experience a family characterised by extreme abuse, if you experience sexual abuse, severe neglect, that has a profound impact on a child's behaviour. a child's psychological development, and it would be strikingly surprising if that wasn't represented in the brain. So, but I think what's important to realise is that that is not damage. These are, if we know that soldiers exposed to combat, when they return, their brains are different. And the brains are different in this.
This is why I say just be incredibly careful of the language you use and and I speak as someone whose father died in childhood. So be very careful if you're suggesting that somehow that leads to some sort of damage.
But I've already pointed out that my entire...
I just wanted to... Sorry. To pick up on what Sue and Rosalind were saying, because was it that you were suggesting that if you sort of label someone as vulnerable, you risk them becoming more vulnerable and risk it sort of self-perpetuates? Is that what you were trying to sort of warn us about?
Can I just respond first of all to the question?
Sorry, I just...
Sue and then Aidan.
I think it's this business about what has happened. I mean, my father died when I was a child as well, so I have a similar reaction. But to the net widening aspect of it, Aidan's talking about children who are kind of they are presenting clinically. So it's about trying to understand what might be going on behind that. I completely agree with you, and I think we are seeing some very troubling precautionary behaviour by the child protection system in terms of getting children out in case their brains are damaged, which is the unhelpful narrative that has been flying around. So I do think it is problematic, and I think it does have to be. The language is really important, and at the moment I am concerned that there are aspects of the way the ACEs are being described which could do two things actually, and it's interesting what Mark said about the reaction of people with ACEs to the video. It could mitigate behaviours in such a way that and it actually says it in this particular video that I've seen, it's not me, it's my ACEs that has, done whatever it is. And it can create a self-fulfilling prophecy, not necessarily because the child's thinking it, but because the teacher is, or whoever.
Ross?
Yeah, I just wanted to add that growing up in extreme poverty, being hungry, living in bed and breakfast accommodation in one room with 3 siblings and your mum and dad, and not being able to go out to the toilet because the other people who live in the bed and breakfast accommodation are very damaged and unpredictable. The stigma of growing up in poverty is also, all of these things are going to have an effect, and they are going to include health. And so I would just, if we're going to talk about adverse circumstances, I think we have to take those social factors into account.
And Aidan, quickly.
So I completely take Vicky's point. I mean, my whole work in the field of neuroscience from the outset has focused on a narrative around how vulnerability becomes embedded and around adaptation. The damage narrative in terms of brain development was one that was prevalent in the 2000s, in the first 5 years. I think people really have to grasp that because something is biological doesn't make it deterministic. The brain is there to learn, and we all learn through experience, and therefore the brain will change. It's completely unremarkable to me that occurs, whether somebody's from a wealthy environment. They will have a different brain, that they learn to play the piano. They will have a different brain. Your brain changes. So I think you're absolutely right that language is crucial. And very briefly then, to stay on track, the ESRC have recently funded me and my group to develop a set of materials for professionals and foster carers, in which we hope there will be a helpful and constructive set of language and terms that young people are willing to support to describe the way that this unfolds.
Thank you, Martin. And a reminder about keeping answers tight.
Questions that have long answers to them. If we turn it round then, children who have suffered ACEs, let's use that language, not all of them then subsequently develop. How much research has been done both at an epidemiological level and maybe at a more localised clinical level? How much research has been done with regard to those? Why don't they fulfil the common story? Who wants to?
If you're talking about resilience and learning from those individuals who don't develop these disorders, I mean, I think because so much research has been organised around a medical model, people have tended to look at those groups presenting with difficulty, and we know remarkably little about how resilience actually unfolds. So I do think there's a major gap in terms of our understanding of resilience and what it actually means. I think it's really important to make to understand what we mean by resilience. It's not something that's in the child or the individual. It's how the child is able to elicit help and use help from around them. But it's also about the social and physical resources around the child. Do they have access to some more supporting and cultural opportunities they can use? So it's both it's a transaction between the child and the. So people say that social support, for example, there's good evidence that that is associated with a resilient outcome, but people may have access to social support but not be able to use it. So we basically don't understand well how resilience unfolds at an individual level.
I mean, it's absolutely right. We tend to focus on the people where the life course has gone very wrong. We are looking at resilience factors. There's been a review by Harvard of resilience factors, and some of the things that come out of that are access, routine access to a trusted adult, community engagement. Those sorts of issues seem to provide some sort of protection from individuals who, as I mentioned, may be suffering from adverse experiences elsewhere in life. And of course there will be biological differences as well. I mean, so there'll be differences in there as well. But in essence, it isn't a deterministic outcome, as people have said. And there are things we're starting to understand around resilience which might provide protection for certain individuals.
So there's no real way of identifying people who've suffered ACEs from those who will then go on to experience negative impacts from it. It's really all that is presenting are those who have suffered, obviously enough, because they're seeking help.
But I think there are studies where people have looked at individuals who self-report ACEs who are fine.
Right.
And look, the problem is that those are generally large population-based studies where we haven't got the granularity to understand what the developed mechanisms might be. You really need a longitudinal study that's observational and that has a theoretical framework behind it to think about what those mechanisms might be and measure them as we go along.
I think that the Mark just said it before, that there has been, certainly in children's social care, a shift away from community support activities and building resilience in communities, partly because of things that have happened in communities that make it harder to do that, but partly because it's been very unfashionable. And part of that has been a discourse of child-centeredness. I'm only here for the child, I'm here for the child, I'm the child's social worker. This has very profound unintended consequences in that people aren't looking at those social and environmental factors, which self-evidently, if you can't go out of your house because you're scared, that is going to affect your ability to look after your child. And is it okay for adults to live in cold houses, but it's not okay for children? There's something very contemporary about this preoccupation with adverse childhood experiences, which make complete sense clinically in terms of trying to look at what might be vulnerabilities coming from childhood. But in policy terms, what do we do? It's really, it skews conversations, it impoverishes vocabularies, and people don't talk in sufficiently complicated ways about what can be done to help people. And what people need is what we all need: somewhere to go, somebody to talk to.
Just before Mark comes in there, would you agree? Would you agree, Sue, though, or do you think that the sort of fashionable, and I use the word carefully, simplistic nature of an ACE? It sounds easy, it looks good, I can throw it out in a child protection meeting. Are you concerned, or I'm getting the understanding that you are concerned, that the language is being used far too widely to describe an extremely serious and identifiable, although there's arguments about it, it's sort of just being adopted as a coverall to explain everything?
That is the problem with concepts, particularly when they've been designed by Frameworks Institute, which this one has in part been augmented by their work. It is packaged to persuade, and it is persuading people, and it's not necessarily persuading people in predictable ways. And because we have got this panic about children as kind of atomised things that don't live in families or where families are toxic to them, it leads to really quite expensive interventions sometimes, which are very time limited and treated almost like a drug. Go on this programme, do this, do that. And it's interesting the NSPCC are working in ways to kind of build community resilience, and I think that's something that needs to be looked at. It's about doing things that are sustainable, that make people feel potent and hopeful, not
Mark, I think you wanted to...
I just wanted to say, I mean, this sort of thing is in all sorts of areas. So people look at socio-economic status, and people who are clumsy with language would say things like, oh, much more likely to be criminals in that area than this area. But the reality is that the vast majority of people in that area were never likely to be criminals at all. So, but we shouldn't get rid of the concept because people are clumsy with language. The thing with ACEs is a powerful epidemiological tool for explaining how impacts in childhood affect people across the life course. It doesn't mean that it affects everybody that way, in exactly the same way that poverty doesn't mean it affects people in that way, and we do need to be careful about how we frame it.
Yeah, I just wanted to say that, you know, children are embedded in families, not just parents. You know, there's wider networks, extended family, friendship networks, the wider neighbourhood. There's situations locally in terms of service provision, and then there's the national policies about that. There's social attitudes like racism and homophobia and so on, that are all things that we might want to sort of look at, as well as ACEs, and that we might want to say that actually it's, you know, it's very good to look at issues that factors that enable resilience, but we might also want to think about stopping the things that people have to be resilient to because they're bad.
Agree with that. Just to look at the factors that improve resilience, though, how much research have we got about work that works on improving resilience? I know I was reading somewhere, you know, sport always gets held up. Do sport and you will be more resilient. But you've talked today much more really at community level resilience and factors that have to feed into that. What evidence is there with regard to factors that improve resilience? Is there any evidence?
I think there is evidence, and I think this has been said. There are some factors associated. So when you think about promoting resilience, it's about promoting the child's ability to engage, to use the resources that might be around them, and the lack of trust and the hypervigilant approach. These adaptations can be unhelpful in the child actually using resources that might be around them, but there is evidence in terms of resilience that availability of supportive families, wider families, peer networks, a supportive community that a young person feels they belong to, those factors are all important. So there's those social factors, and there's good evidence that those are protective, but also the availability of cultural and sporting opportunities where a child can develop a sense of agency, a sense of self-esteem, and a way to build a more proactive sense of having control over their lives. So you need those physical resources and opportunities and social opportunities, and there's good evidence, I think, that both can act in a resilient promoting way.
Very quick, just hearing what we're saying, it's fascinating. For a child that has adverse childhood experiences, do they think it's the norm, or are they capable of benchmarking it against a friend's house, their auntie's house, or a neighbour's house? How does that come into the equation, or does it not come into the equation?
I think it's a matter of degree, and it's a matter of the cultural context in which people live, and it's dogging this whole discussion really is this issue about severity and what we mean by an ACE. So a child who's experiencing severe sexual abuse, I mean, they may have a period where they don't realise that not everybody is having to endure this, but they will surely soon find out. But there are other things, like the sorts of situations that Ros has been talking about, where everybody is living in very difficult circumstances, and it probably does feel quite normal, not nice, probably quite horrible, but normal.
Yeah, I've covered the main points. I'm very conscious of time.
Thank you very much, Graham.
I'm not sure whether the committee is witnessing a
a turf war between two professions or not. I'd like sort of Professor White and Bellis, if you could say what the argument is briefly and what the policy consequences are of those two different approaches. I think that would help me.
I think that there is a lot of agreement across the panel that early experience matters. ACEs represents one framework that people have developed where a disparate array of risk factors have been grouped together. I think the debate is about the appropriateness of widening that net in terms of a policy level. Epidemiologically, it has been helpful statistically to look at these things, but you're mixing lots of apples and oranges and things that aren't even fruit, potentially, within that mixture of what an ACE is. So I think ACEs have been helpful in shedding the light on the need to look at adult outcomes through the lens of childhood experience. But the difficulty in terms of policy and practice is that different kinds of early adversity have different impacts and effects, and they will need to be thought about differently, and we can't simply reduce it to one underlying score. So a child experiencing sexual abuse will be quite different from a child caught up in a terrorist attack, potentially, and we need to think about how early adversity can be thought about in terms of treatment and prevention. But to come back to the point of resilience, the factors associated generally with resilience are access to stable, trusted adults, having stable peer relationships, and having environments that are rich enough with cultural and sporting opportunities that children can use to develop and increase a sense of agency and self-esteem.
Does anyone on the panel disagree with that?
No. But can I, on the turf war, I think most of us do agree, and that's another thing we agree with. It's partly to do with whether it's at the clinical end of what we're talking about or the population end. And at the clinical end, putting everything in one basket is not necessarily helpful. On the population end, when you're thinking about dealing with people, perhaps if you're a teacher, understanding the relationship, or a frontline police officer, having an awareness of how adverse experiences might have an impact, being able to deal with some of those things at a lower level yourself, or the skills to understand when you need to escalate them and understand more about them, that might be an important thing, which means lots of people, most people potentially, who have ACEs get access to some sort of support earlier.
Sorry, can I just... That is actually the problem, because this is all at the aggregate level. A teacher cannot look at a child and say, you have got ACEs and you need this intervention in order to prevent this. It's very good for alerting attention to an issue for us to think about in terms of broad policy terms, but it's not good when people start tick this ACE, tick this ACE, tick this ACE, tick this ACE. This child needs intervention.
I agree.
Yeah,
I agree.
What is the evidence of early interventions undoing the sort of physiological or psychological damage you've told the committee about?
It depends what it's mixed, as you would expect, and there are usually for parenting programs and things there are some modest effects that do have a tendency to wane over time, which is not particularly surprising because actually you only have them for a short period of time and they're probably quite helpful, and that's part of, I don't think it's a turf war, but that is certainly part of what I'm arguing, that there has been a shift towards there being particular slices of help that are provided for short periods of time, usually focused on parenting practices. And that would be all right if it was as well as a range of things that do all these other things that we've just talked about, how important they are in relation to communities and hope and that kind of thing. But it has shifted quite dramatically. So yes, there is evidence that going on programmes of various sorts, and there are many competing ones, has some impact, but is it going to cure all social ills? No.
And it depends on what you are expecting the outcomes of those interventions to be. So it may be that the intervention does nothing to prevent smoking behaviour or whatever, but the person who is receiving it, mothers usually, feels really good because there's someone who's interested in them, who comes round once a week to have a chat with them. I'd say that's good. That's a good enough outcome if someone who is living in difficult circumstances feels better about themselves. But that is not what the programme would be judged on, because that's not considered an outcome.
There are a number of programmes. There's things like Safer Environment for Every Kid, which starts earlier on. They're about identifying and working with parents who are expecting children or very early on in having a child where they might have a history of mental health or alcohol problems or of domestic violence in the house. And there's some trials around there which have been fairly good at preventing ACEs. There are family interventions like other people here have spoken about, like Family Nurse Partnership and Triple P and others, and they're about supporting parents. And then there's others which work on things like preschool enrichment, which are working actually with the child and the parent to give them enhanced support earlier on. And so there are a number of programmes which are largely supportive. I don't know of many that actually, as you go later on in life, that have been there, but there are some examples of schools that have adopted ACE programmes successfully. And had, but not necessarily in this country. The most famous one being a school called Walla Walla, which in the USA.
We may hear more about these in due course, but I'm conscious we've got to get to the second panel, so we need to keep it tight. Graham.
I'll try and keep it tight. How reliably do you identify those in need of early intervention?
I think this will raise an important question about what you regard as early adversity. I think that there is a need for the field to develop a more preventative approach. At the moment, there are these interventions that seek to reduce the likelihood of significant adversity, like the Family Nurse Partnership, and there are interventions designed to treat children presenting with clinical level problems, ADHD, conduct disorder, but we know remarkably little about how you can prevent the emergence of disorders in children who've been exposed to what we all might call a significant level of abuse or neglect. It's been a remarkably neglected field because these children generally have not been seen as a public priority. They generally don't get significant resources.
I take it from what's been said already that there would be agreement across the panel that the earlier the intervention, the better.
Well, again, it depends what you're trying to do. So the Family Nurse Partnership is a really good example there. It takes a category, young mothers living in difficult circumstances, and let's intervene early before anything happens. The randomised controlled trial of the Family Nurse Partnership showed that most of the outcomes that it was supposed to achieve were not achieved. One explanation for that is because, in contrast to the United States, where the programme came from, is that we have a universal health service and health visiting and so on. But it did have some effect in terms of mothers' feelings of confidence. But it didn't have the other sort of measurable outcomes that were shown through they weren't shown through the...
But in response to Graham's question about the importance of early intervention...
Intervention is what for?
I think there's a risk, just very briefly, I think there's a risk of thinking that intervention can only be early. We know from our brain development studies that the brain continues to develop into early adulthood. Adolescence represents another important window of opportunity. I think there's a risk at times that the narrative has been the first 3 years or the first 2 years. The child continues to develop, the brain continues to develop. Of course, there are windows of sensitivity and vulnerability, but there's also windows of opportunity across the child's life. And as Rosalind said, I think that it depends what your aim is. Of course, early intervention, if we can do it, is best, but it's important and valid throughout the lifespan of the child.
And there is a tendency to think about clinical intervention immediately, but and I would as a public health person, a lot of those interventions will be by families themselves, by people around them. The more they understand, take the word ACE out of it if you like, about the importance of the support, how they can give resilience in earlier life, much of that can be delivered by non-professional individuals, so long as they understand the importance of addressing those issues.
Been answered.
Stephen.
Yeah, very briefly, conscious of the time. I suppose really my question is, where do we go from here? Do we need more research, and if so, should that research look like, and what will it tell us that we don't already know? Or is it now about actually agreeing on some practices and getting out there. I mean, you said, Sue, bad things happen to kids, they always have. We know that. Knowing more about that isn't going to necessarily reduce that level of risk. So it's, what should we be doing from here on in? Should we be investing in research, or is that we know enough to know what to do?
I think it depends what you're researching, and I think there are some things that you know, of clinical importance that biomedical research will research. I think that there is a tendency, I mean, for example, before I came today, I did yet another search on Google Scholar for how many papers are there on the response of the HPA axis to stress. 170,000 hits. Okay, so you know there is a lot of research going on. So it's a bit paradoxical because I am a researcher for me to be saying this, but I think that there is a danger that a lot of money is being spent on research that is useful, but it's scientifically interesting. It's not necessarily going to solve this. Whereas I do think that there are some quite simple things that could be done, which just require us to be reflexive about what we need, and to treat people who are in adverse circumstances, because they usually accompany the more severe end of what we might call ACEs, needing ordinary help, which I prefer actually to intervention, you know, because intervention sounds a bit like being poked with something. It's people need something more simple often. That's what early intervention would be for most people. There will be babies and children who are in frankly abusive situations, and that's what the child protection system's for, which is creaking badly, but that is what that's focused on, because as a society we have thresholds of what is considered to be acceptable and unacceptable parenting, but they are very contestable and they shift.
In terms of research, I think that it is worth making a shift from sort of persisting with ever refinement in measures to actually sort of thinking about supports and looking at supports and a whole different range of sorts of supports. Obviously, you know, sort of how, you know, the enabling you to get by level, and if you've got a neighbour you can pop into and borrow sort of £5 to see you over, and they, you know, vice versa and so on. That's really great. I think that we are at risk of forgetting these are people in terms of measuring them, and that actually speaking to families, talking to parents, talking to children about what would make their lives better is worthwhile alongside the other sorts of research.
I'll try to be brief. 4 points. First of all, I think prevention requires significant focus. We don't really understand how disorders develop over time. There's a massive research need to think about how problems evolve and unfold. So much research is focused biomedically, as you say, on medical disorders, ADHD, conduct disorder, autism, that kind of thing. If we don't understand how disorders unfold, then we're limited in terms of optimising our approaches to intervention and support. My second point would be absolutely that young people and children need to be meaningfully engaged in decisions about their care. They need to be seen as active agents who are engaged in making decisions. I think for those children who experience maltreatment, their difficulty should not be reduced to a list of symptoms. They have a holistic set of needs, socially, educationally, in terms of their relational development. They need to be thought about as whole people and with a complex set of needs. And at the moment, often they're referred to CAMHS and their difficulties are reduced to a symptom and a diagnosis. And finally, I would say that there is an important thing that has come out of the ACE debate, despite the mixed kind of views that we have, is that we need to understand, we need to help others understand that early adversity and traumatic experience can have an effect on the way children behave and the difficulties that they present with. So teachers understand that the child may be behaving in a certain way because they've experienced domestic violence at home. So there's a way in which there needs to be greater education and training for professionals, carers and teachers.
Very quick points. I think there's enough evidence to merit action. A lot less has been done, a lot more has been done with a lot less evidence than there is at the moment. Of course, there'll be research questions to answer along the way, but 700,000 England and Wales births a year, a large proportion of those will have some form of exposure to ACEs. The more that happens, the more problems you've got for those children at this time and in the future. It's a public health problem because it's a large population issue, and information out there to people is critical. That can be done. We can work more on prevention, and there's a range of services that can come in that. There's a range of other services that can help with support on resilience within that sort of framework, and there is a trauma-informed system about ensuring that the people who are seeing those people who've got through understand some of the impacts of ACEs and the life course approach. While people debate the research and the evidence, if you approach ACEs and try and tackle ACEs, the worst that can happen is that you just tackle adversity in childhood, abuse, neglect, domestic violence, and the potential benefit, if people agree with the life course approach, is you also get a benefit for those individuals for the rest of their lives in terms of health outcomes.
Just one final question, Chairman, and it's specifically to you, Eamon. I think in your written submission you suggested setting up or the equivalent of a Harvard Centre for the Developing Child. How would that differ from the Early Intervention Foundation that we already have?
I would say that the Early Intervention Foundation largely collates information and research and helps disseminate that. I think there's the Harvard Centre, but there's also the National Council that the US has, which is a multidisciplinary group of academics and disciplines that bring together our understanding around these different areas in a much more proactive way. At the moment, the field is very fragmented. People look at these different aspects of childhood development, and I think there's need for more of a leadership role, I suppose, than the Early Intervention Foundation provides, that is led by people in the field who are clinicians, who are researchers, who are involved in social work, involved in education, a multidisciplinary group that can help inform policy and practice and translate what we know about the science into to a language that can be understood.
But hopefully does not run the danger of being so invested in its concept that it cannot find negative.
And that's why it needs to be multidisciplinary in its structure.
Okay, thank you.
We've reached a point of agreement there. So thank you all very much indeed for absolutely fascinating discussion. I appreciate the time, and I'm sorry we've taken up more of your time than we'd expected. Thank you. Can we have a quick turnover as we've got to get on to the second session? Thank you very much indeed for coming. Thank you for your patience. Can we start with very quick introductions, starting on the left-hand side?
Yes, good afternoon. I'm David McDade. I'm an Associate Professor in Health Economics and Health Policy at the London School of Economics.
Thank you very much.
Hi, Professor Leon Feinstein. I'm Director of Evidence at the Children's Commissioner's Office, and I was at the Early Intervention Foundation until
Thank you.
Mark Bush, I'm the Chief Policy Advisor at Young Minds.
Thank you.
And Kate Stanley, Director of Policy and Evidence at NSPCC.
Thank you. And again, the plea, as you've noted, we've run heavily over, and we've got to try to keep more on schedule in this panel if we may, so a plea to you to keep your answers as tight as possible. But can I start by asking, how can evidence linking adverse childhood experience, however we define it, to negative impacts later in life inform efforts to improve children's and adults' well-being? Who wants to start? And don't feel you all have to answer every question. So none of you want to answer?
I'll start.
Okay.
Polite. Okay.
Yeah, exactly. Yeah.
In a way, we can answer that by looking at what's already happening. So we've got a fantastic example of what could be done if we wish to do so in Alberta in Canada, where they have gone wild for the ACEs agenda, and with the help of philanthropy as well as the provincial government, rolled out a programme of understanding the ACEs tool and the ACEs research and how it might be used across the public and voluntary sector. So you've got teachers who are on training to understand brain development and childhood development. You've got medics doing the same thing, and you've got policymakers also engaging in learning about early childhood development. And you can start to see the galvanising power of that approach in play in Canada. So you can see policymakers making decisions that say, in order to provide this service, you need to have this understanding of early childhood development, and it rolls on. And what you can see essentially is a galvanising shift where people have got a common language with which to talk to one another, and a common understanding of what children need to thrive, and an awareness of how that can be adversely impacted by experiences.
And do you think the approach that they're taking in Alberta avoids some of the risks that the first panel talked about?
Yeah, I mean, I think there's some of that, and people telling the tale of what's happening there will sometimes describe it too simply, but so there is a little, they're learning as they go. But the point is, what it's doing is it's putting adverse childhood experiences front and centre. It's making it an issue issues that are talked about in a way that, for example, child abuse was never a public health issue before. It is now. Yeah. You can't get away with pretending it's not. Suddenly, it's putting a lens on things that were given no attention earlier.
How long has this been underway in Alberta?
It's a programme of investment over the last 9 to 10 years.
Yeah. And it's not a trial, they're just doing it.
Yeah, it's being done.
And is there any emerging evidence yet about impact, other than the galvanising effect?
Yeah, so they've collected rigorous process evidence to understand how this programme is rolling out and what the kinks are and what the problems are and where it's been too blunt an instrument and also where it's working. So they've amassed a strong body of evidence. What they found that's most profound is that using the ACEs tool gives people a way to talk about what's happened to them. And it gives professionals a way to ask the right question, which is not what's wrong with you, but what happened to you, which then sets up services in a different way.
And you don't think there's a risk of this sort of self-fulfilling prophecy that was talked about earlier? That people then define themselves by the fact that this is their experience?
Well, I mean, that sounds a bit like psychobabble to me,
yeah.
if I'm honest.
Yeah.
I think they're having the conversation about their lives and what's important to them, and that then opens up a conversation to services, and then services are being commissioned in a way that responds to what people say they need.
And you would prefer that to abuse being ignored or not talked about?
Absolutely. And I think giving people a chance to talk about their needs and experiences isn't a bad thing.
Thank you very much.
The previous panel gave a very good summary of the different views. The two things I would add, one is that I think the approach, and I've seen it in Blackpool and other towns, where it's useful, is it enables a whole cadre of professionals who are not experienced, as Professor McCrory is in talking about early trauma, to engage on the question of trauma. So getting police officers thinking about why people are behaving the way they're behaving, and then it's trauma-related rather than criminality, enables a whole different series of interventions, and that's very useful. The risk of it, I think, was slightly understated, and that's the overselling of it. And I do think there is a risk around the overselling, because I see a lot of figures about how we're going to identify 80% of children who need help from this method, and the numbers are inflated because of the methodology of the studies that have been done, and because of the difficulties of actually understanding trauma and who has actually experienced trauma. And this set of checklists and these tools, I think, are useful, but I do think there is a danger of overselling, and the result of that then is people get disappointed and they throw the whole thing out.
That underlines the case for doing something. Mark?
So I'd agree with Kate. I think there's a really compelling reason to talk with these terms, not necessarily being totally kind of married to them, but using them as a framework for convening public mental health interventions, thinking at a population level, but also starting to think about what multidisciplinary interventions look like. When we actually get down to service level interventions, actually there isn't great data and evidence. We don't know what the best impact looks like in terms of trauma-informed schools in England. We've compiled, which I know has gone to all of you, all the evidence relating to England. We've seen the evidence that's emerging from both Wales and Scotland. We have a sense of what those are, but I think the best place we can get to is that we have a set from where the evidence sits of what the shared principles for both adversity and trauma-informed care look like. And they're well evidenced across a range of adversities and across a range of interventions. And I think why it's important to think in those terms is because actually the interventions we're trying to do here are talking about multiple populations. So what's kind of buried in your previous conversation you had with the panel is we want to reach out to children, young people who face adversity and experience emotional distress, like 100% of us do, but actually have no traumatic stress as a consequence, won't go on to develop diagnosable mental health conditions. We also want to reach out to that population who have pre- and subclinical levels of emerging mental health need. They're children, young people who, for instance, act out, they become aggressive because they don't have a different way to communicate. They, for instance, might take substances as a way of coping with high levels of agitation or stress. They might get involved in a circle of violence because that's how they survive in their community. And we want those behaviours to be interpreted in a different way. And if we learn from youth justice interventions, if we learn from early interventions on a community level, actually addressing those behaviours and understanding them as arising from adaptation, as Professor McCrory is talking about, is a really helpful starting block. But then we also have a third group, which is children, young people who have a diagnosable mental health condition, which will endure and which they will manage for the rest of their life. And we know that the evidence does show that at least 1 in 3 enduring adult mental health conditions directly relates to adverse experiences or the experience of traumatic stress. And that's at least, and it's a compounding factor in the rest. So as a consequence, all of the evidence base needs to be about how do we intervene at those 3 different groups, and also what are the general principles working across the range of adversities. Because actually, whether you're a teacher on the front line, a nurse, a police officer, there are some really simple, practical, evidence-based things you could do to not re-trigger to someone, to not re-traumatise someone, and actually to improve outcomes, whether or not they go on to have enduring mental health problems or traumatic stress. And they're cheap, they're not expensive interventions.
Thank you. Question directly to Leon, if I may. How does the ACE framework compare with Children's Commissioner's vulnerability framework, is the way it's been defined by you? What evidence has your framework uncovered so far on the impact that adverse experiences can have on children's lives?
Can I ask a question? If I can just distinguish 4 uses of data, because I talk a lot about this, and these get conflated, and that causes confusion. So we need data in order to understand 4 different things as social policy work. So one is the strategic overview of what the levels of need are in a place or in the country. What are the issues that policy needs to address? It's a kind of aggregate analysis of need. We need data in order to be able to target individuals who might benefit from specific interventions or services. We need data in order to monitor activity and understand whether it is being delivered well, and we need data retrospectively in order to evaluate what the overall impact was. And those four are very, very different. The work that we're doing at the Children's Commissioner's Office is very much about the first thing of trying to understand aggregate levels of need. So we're not developing tools that would enable a frontline practitioner to interview somebody who was in a particular situation and work out whether they had experienced some form of vulnerability. The aim of the work is to understand, working across the different interests of different bits of government, local and national departments, what are all the different groups of children who might be considered vulnerable, and to understand what we know about those levels of need and what the services are that those different groups are getting. So it's very much an aggregate analysis. And I would say the other difference is we are deliberately descriptive. We're not trying to determine what the causes of those problems are. There are big issues about what is causing different levels of vulnerability and need and what the solutions ought to be. But the analysis that we're doing, and that's my criticism of the ACE in a sense, is that it's trying to do a multitude of different things. It's not always clear which of those things it is. So where it is a descriptive exercise, the business of having a set of 10 indicators that tell you about possible trauma, I can see as useful, but those descriptive variables very quickly become seen as causal, and we're really trying to avoid that. And what we're doing is just descriptively asking how many children have different levels of need on different definitions.
You saw the play out of a debate over the use of concepts, and this is perhaps an area that we part ways with the Children's Commissioner's Office. And I think that's because actually within a vulnerabilities framework, it's making, I think, two fundamental mistakes. Probably the first one relates to how Public Health England usefully categorises both vulnerability and adversity. So actually they talk about identification of need, which is about behaviour sets that are visible amongst children, young people who experience different things. They also talk about primary prevention in terms of adversity, which is the circumstances in which people find themselves. And then they also talk about primary prevention, which talks about vulnerability, which I wish they and the Office for the Children's Commissioner and actually Professor Corey wouldn't use, which actually describes characteristics which might be relating to biological features or might be relating to a particular characteristic under the Equality Act. Why it's important not to conflate those things is because, A, some of those things aren't about the inherent vulnerability of the child. And in a narrative which is using the term vulnerability, we're actually abdicating responsibility from the circumstance around them and actually not taking a public health holistic view. Also, actually, in conflating all of those things, we're saying that the intervention level is all at the same level, and that's not quite true. So I think vulnerability was a useful term for the 80s, 90s. It was a way of talking about the inherent vulnerability of the child, but with the advent of children's rights, with the advent of a more complex way of thinking about interventions, vulnerability is probably, as Public Health England have come to realise, one of 3 or 4 ways that you would describe things.
Very quickly, Leon, because we've got... Yeah, okay. Now, we're focusing in this inquiry on early intervention, but what would you define by early? What should we helpfully understand by that, Kate?
Either in terms of age, so soon on in life, but as was mentioned earlier, just because it doesn't happen soon doesn't mean it's not valuable later. So early is best, later is acceptable if that's all you can manage.
And why is it best?
Because if you think about building a brain as like building a house and brain architecture, getting the foundations right is a good thing to do rather than make modifications later on. And building a brain is similar, it's built from the bottom up. So early in terms of chronological age, but also early in terms of the sooner the better. And I just want to come to a point made by Professor White earlier, which seemed to imply that the ACEs agenda had caused child protection services to rush in too soon. There's no evidence to substantiate that claim at all. We're seeing child protection services cut to the bone, and they're waiting till the very last moment, very often times.
I was also slightly confused by the suggestion that there are lots of prevention services emerging all over the place. I haven't really witnessed them, certainly in my experience in my area, but do you want to add anything on that?
Yeah, that and also community support. So there was a lot of talk also about the importance of community support and family support, preventative services. All these things are excellent to have, but part of the reason why we're having the conversation about ACEs is because we're talking about what to do once it's happened, which isn't the conversation we really want to be having. It's how do we stop ACEs happening in the first place. Okay,
thank you. Leon?
So the Early Intervention Foundation definition of early intervention is activity that is upstream. So it's preventive activity, and critically it's targeted activity. So I want to make a distinction between early years activity, which might be universal. It might be dealing with maltreated children, or it might be targeted. Early intervention is the targeted element. So we make the distinction between early intervention and late intervention, where late intervention is what happens once children are in the acute or statutory system and services are having to intervene for statutory reasons. The Early Intervention Foundation, we estimate that just the fiscal cost of late intervention with children up to the age of 18, the immediate fiscal cost, never mind the long term, or the social cost, the immediate fiscal cost is £17 billion a year in England and Wales. That's the cost of activity for children once key thresholds have been crossed. So they're in the criminal justice system, or they have been taken into care, or the police have been called out, or they're receiving Tier 4 mental health support. The total cost of that is £17 billion a year. Now, we know the social costs and the economic costs and the intergenerational costs and the long-term costs go way beyond that. This is just the immediate fiscal cost. The point about early intervention is it is upstream of those thresholds. The reason why I don't agree that it's always best to intervene early is the key to success in early intervention is accurate identification of need and meaningful response. And it's not always the case that you can identify the mental health difficulties of a 2-year-old.
Then you do agree with it?
I'm sorry?
If you can meet those two thresholds that you've just described, then you do agree with it?
Well, it should be early as in upstream of crossing the threshold, not early as in early in life necessarily. Because early in life it can be very hard to identify accurately what the actual needs are. So there's a danger of very inefficient forms of early.
Can I ask, do current support services reflect the evidence base on adverse childhood experience?
No.
No.
So I don't come at this as somebody who thinks the evidence base on early childhood experience is altogether the relevant evidence base. I think there's a lot of evidence in psychology, in economics, to a certain amount in neuroscience, although not at all necessary to the case for early intervention. There's a lot of evidence in the literature on program evaluation and in what is known when people try programs and they test and they learn and they adapt. And we know a lot. And I did want to comment on the business case in relation to early intervention. Having advised on this now for about 20 years with different administrations, it always comes back to the question, do we know it works? We know that if you deliver high-quality services to people that need them, that have the right features of quality and they're well delivered at the right time, they can be transformative in most circumstances. We know very little, just to finish on that point, early intervention describes a very, very, very wide array of different sorts of activity. What works for who, when, we don't know enough about. So my point on all of this is we know enough to know that it can work, and we have to get the barriers out of the way to making it happen, and we need more testing and learning. But the question is not does it work, the question is when does it work and how to make it work more.
I don't want you to feel left out of this discussion. And your time will come a little later in terms of the sort of economics of intervention. But I think you would say from your written evidence that there's plenty of evidence of early intervention programs that work and that deliver an economic return. Is that right?
Yeah, absolutely. Both from the from pre-birth and the perinatal period in terms of interventions to help mothers and children there, all the way through to young people leaving school, and indeed the transition to work and university and other outcomes. So there is an evidence base. It's increasingly strong evidence base. I agree with Dr. Feinstein. There's a strong economic case with many of those interventions as well. The one thing I would say, though, at least from my view of the sort of economic literature alongside the effectiveness literature, is sometimes we're still relying on interventions where the primary evidence is from a different context. And we just have to be a little bit careful about that. That's not to say that we shouldn't do that, but we need to be mindful of how it needs to be adapted, whether or not there are factors at play. And indeed, this was in the last session as well.
You mean translating what might be happening in Alberta, for example?
Absolutely, absolutely. Just been a little bit cautious, or just to consider what differences may be at play.
Martin, thank you. Who's best placed to spot the need for early intervention? Whose shoulders should it rest on?
So frontline practice.
So frontline practitioners.
I think we all agree with that.
I would say families.
And
families?
To seek help.
Mm-hmm.
That's usually where it begins.
Well, it depends what you mean by practitioners as well, because I would see a role for schools and kindergartens and so forth.
That's what you meant by practitioners. So those who come into contact with the children, obviously families right from the start, but those at the earliest opposition. If we put aside families, or if we don't actually, aren't families the best place to spot it right at the beginning? Is it not almost too late when it's the nursery teacher,
We're not in situations where the adversity relates to the community or the family. So I think very much what we think is the missing jigsaw piece here is understanding how you create adversity and trauma sensitive and informed practice across the board. And that's where actually you don't need specific service lines at expensive cost. So when Future in Mind was being created, the government's big strategy around this, there was an aspiration to look across all of these groups and say, how do we intervene early? How do we identify need? And actually, how do we upskill all frontline workforces to understand how to, including parents, understand how to intervene? And what happened was, when the DH and others brought people together, they said, this is far too complicated. You know what we should do? We should go back, because of evidence reasons, just to single adversity and think about interventions lines in that. So we've had great progress on looked after children and care leavers, great progress on child sexual exploitation, but actually there's translatability, not policy transfer, I mean practice translatability across those groups. And actually there is good, well-established evidence across a range of the fields that if you create practice spaces in any frontline practice which understands adversity and trauma, the consequences, how people present, and what a good response is. Actually, you de-escalate need, you divert people away from specialised services, and you prevent an escalation of mental ill health and other physical health consequences. So for me, that is an important way of stepping forwards in terms of this. Otherwise, what we do is we constantly say the threshold of evidence hasn't been met. We need to just go back into a silo working. There is nothing to be learnt across these adversity groups.
So to extend that, I mean, would you say that, different early interventions need to target the whole population, communities, families, all the way down to individuals, and we need the diversity of toolkit to draw on, and we need the knowledge in frontline individuals to be able to identify what works well where?
I think you're totally right, and that's why Professor White's intervention, I think, was a bit of a red herring. So we've been calling on directors of public health to champion interventions across actually all workforces at a local level. The reason for that is you keep the integrity of looking at a population base split across those three different levels of groups of children, young people that I was talking about, but also they are well placed with no particular investment in any model or in any of one of those adversity groups to say, look, if you're a police officer, you might come across any of those groups. If you're a teacher, you might have children who are falling asleep in your class because they are taking on adult responsibilities. And on that basis, they are very well placed to think about what a coordinated response will be. So yes, it's about upskilling all frontline practitioners, but it's also thinking about coordinated pathways and support which are sensitive to this. And then just, if I may quickly, on the early intervention definition point, just remembering that actually the reason why we need to think about it in a coordinated way is, as we know after the terrorist attacks, that there is good reason that the NICE guidance specifically says don't intervene straight away. leave a moment where actually people are able to reintegrate into their community and have a sense of what that impact of witnessing those events were. And actually by intervening too early, you might exacerbate the trauma that they're facing. So that's why we want it to be held at a public mental health level, because they can think about incidence pathways, they can think about whole workforce plans, and they can think about embedding a trauma and adversity-informed culture across the board.
Do you want to add some?
Well, thank you. I just wanted to say, so yes, frontline service providers in different ways will be very important, as will families, teachers, others, in the identification of need. The challenge for government, I think, is what systems are constructed through which that information gets communicated, and how that works with the huge diversity of structures of service that we have, which is actually different in every town in terms of how and who and who you're going to work with. That is definitely a role for government there, and also in the challenge of understanding the strategic levels of need. So the kind of information you get from a frontline practitioner is very different from what you get from an aggregate analysis. And I want to emphasise that's part of the purpose of the work we're doing on measuring vulnerability, is to get an aggregate framework that then you can set some kind of funding formula in relation to. That is the context within which those frontline services
almost reflects the challenge that we heard in the first panel of the value of, at an epidemiological level, of the ACEs and the reality of it being against individuals. On the back of that, do you think there is any value to a sort of an ACE-based screening tool? Or is it, as I mentioned in the first one, is this convoluted language that's being used to tick boxes when actually it's more complex? Okay.
So generally, the ACE tool hasn't been used directly with children. We've not got enough evidence, so it would be adult-facing. And that has some signs of being useful in terms of people's feedback of their experiences of it. So, and it's something that we're exploring as part of Blackpool Better Start, where we're the partner. So we'll see how that goes. People seem to be getting into quite a lot of conceptual and language debates here today, and I just want to make one tiny contribution to that, which is call it early help rather than intervention, because that just reminds us that it's not necessarily about a statist response to. It's about thinking about how people are equipped with the tools to be able to identify what's going on in their family or the family that lives next door, and to offer help. And what's the value in ACEs as a tool or the body of research is that it has been translated into very simple terms that are meaningful to people, that can be used as a common language and have explanatory power for people to help them understand what's going on in their lives and to talk on a level playing field with practitioners. And I think that has tremendous value, more so than anything that is a screening, because you're not really sure what then.
Yes.
It's not helpful as a triage tool, but it's more as a starting point for understanding what's going on.
And also what's being screened. So if you look at Lancashire, that came up with routine inquiry, which has been really successful in child sexual exploitation, child abuse, and extended to other areas, they've got issues with translating it to under 14s. And when they're trying to roll it out to the rest of the NHS and other children's services, they are trying to tackle that problem. But also, ACE as a concept itself, as translated in those screening tools, has some fundamental problems for children and young people. So, for instance, in the ACE definition of sexual violence and sexual abuse, the perpetrator has to be older than the individual. So, harmful sexual behaviour between peers would be screened out. And actually, the most important premise of this, in terms of routine inquiries as a screening tool, is that you're asking people about their experiences. You're recognising that the way they're saying it might not be story-based. It might be aggressive, it might be withdrawing, it might be falling asleep, it might have whole different manifestations that comes in, and that's used as a basis for action. And I'm using action rather than intervention, because that might be a systemic community and school-based coordinated support about communities of violence, or remove or stopping the integration of, like happened in Barnet, Enfield and Haringey, of girls who were pregnant that were gang members, making sure that they aren't integrated back into gang culture. So action can come once you've identified something, but we wouldn't want it all limited to ACEs because it is too much of a blunt tool.
Yeah, I mean, there's an example where they use, it's actually in Boston in the States, they use the ACEs tool as a screening tool when women join an employment programme. They use it as a way of having a conversation about what's happened in their lives, what's going on for them, and what some of the issues that they may have. But then the rest of the programme, which is all about them getting a job, draws on that, but it's not because of that, it didn't get them in the door. It's just a way of making sure that the help that they then get is better tailored to the kind of life that they've had. So, for example, if you've experienced multiple ACEs, you may have problems with emotional self-regulation, which means when you're in work, you might fly off the handle rather a lot. When someone annoys you, you might react back. So what they do is they work with the women to coach them on regulating their emotions. It's a really practical tool that helps them keep a job.
But that practical tool is routinely asking questions of each person.
Yes.
Which is not too far away from screening.
No, I suppose screening implies it's a route into something.
I mean, my worry if one doesn't do anything in a routine way, then it's quite haphazardous.
Yeah, for them it's routine inquiry. Yeah.
But I guess what we're saying is that the importance of routine inquiry is inquiry and then understanding what is being presented back and taking action. It's actually not screening for a knowable future mental health problem or a knowable early mortality.
As a diagnostic tool to put you on this.
It's about understanding the kind of intervention. And what is great about the intervention-based are they're super practical. They're things everyone can do. So the example I always give is by a good CAMHS inpatient service asking someone about their experiences of sexual violence, they understood that if they stood in front of a door when talking to a young girl, that would be triggering. It'd be triggering of the violence they had experienced, and they would become aggressive towards the member of staff. But until that inquiry had been done, they didn't realise that's why they were becoming aggressive. So they were subject to increased use of restraint, which in itself is re-triggering and possibly re-traumatising. So actually, just by inquiry, it gave really practical-based interventions which are well evidenced and will have a positive outcome. This isn't huge neuroscientific rocket science. It's about understanding what's there, understanding the intervention and the appropriate action to take, and every workforce can do it.
It's about creating that space for the proper inquiry to take place on a one or group-to-one individual basis, which flows the need for time.
Sorry, I'm
going to dump my last question. I don't think I need it, but I'm going to ask this. Do you think there is a danger, though, that those who are not on the front line will start using the language like ACE screening as a shortcut to try and arrive at a decision too quickly and not evidentially based?
Yeah, and even worse than that, because we haven't even talked about the overlap between trauma and adverse childhood experiences, and there is definitely, like there's an industry in the UK and the US for intervening in problematic and challenging behaviour. There's definitely an industry growing up to intervene in adversity and trauma. And I guess what we're trying to say is by taking a public health and a practice-based approach, we can make sure that that is about addressing actual people's needs rather than educating people in a possible conceptual framework over another conceptual framework. Because I think, as Professor McCrory said, actually not all adversity leads to mental ill health and not all adversity results in traumatic stress. So we wouldn't want to conflate those things either.
Thank you.
Thank you very much, Martin. Neil?
I want to ask a bit about cost-benefit analysis on interventions, particularly starting with Professor McDead, if I can. You mentioned in your written submission you think there's huge economic sense in investing in these programmes, and you mentioned, I think, 7 different examples of that. Do you think that those kind of economic benefits are limited to mental health type interventions, or do you think they're likely to be broader than that? And how confident are we in the evidence base that we will find net cost savings from some of these interventions?
Can I just ask, in terms of the question about the mental health benefits, are you talking about the interventions or the consequences of the intervention?
Interventions of other things other than mental health or something?
Well, just addressing that first, I mean, there is a substantive evidence base on interventions other than mental health related that have benefits both in terms of mental health, physical well-being, mental well-being, and you can see a positive cost benefits on those. I mean, sport is a good example, actually, of those kinds of things. Education, actually, Dr. Feinstein knows a lot more about that than I do, but education as an intervention per se has a benefit for an individual's health and well-being. But we can be pretty confident now that the direction of travel in terms of the evidence base on not only what works but what is cost effective is all pretty much all in the same direction, suggesting that there are substantive cost benefits. But, and this is the but, these benefits don't tend to fall to one sector. They tend to fall to different sectors over time, which can make it difficult actually to implement. And it goes back to the issue about implementing and coordinating across sectors, because you've got some sectors paying, some sectors benefiting, you've got some sectors benefiting in 10 years' time, but you know, so there's all sorts of issues there. But so we can be pretty confident there's a good evidence base. We gave some examples in our submission, ranging from from perinatal interventions all the way up to early intervention for psychosis. And indeed, since we submitted that evidence, we've been working with the charity MQ to provide some more examples, for instance, around mental health first aid as a potential intervention to identify people with mental health problems in school. So there's an evidence base there.
In terms of the quality, these are things that are based on randomised control trials, or are they all of those? On the sort of qualitative thing about what sort of interventions are likely to pass the threshold for being economically worth it, about half of the UK's population on some measures have suffered some kind of ACE, and do you think it's likely that sort of interventions that are targeting that kind of broader population are likely to be cost effective, or is it always going to be things that are more clinical, more social work, more targeted?
My personal view, I mean, most of the work that I do, and indeed some of my colleagues do, is more the population health side of things. And certainly there is a strong case for investing in interventions that move the whole population a little bit away from developing poor mental and physical health over time. And we do see that with, for instance, recent work we did looking at interventions to tackle bullying in schools. And you can actually see, drawing on longitudinal evidence, we know that the long-term consequences of bullying, and we can see that these interventions do make a difference in schools now. But just to go back to the previous point that you mentioned very briefly, that doesn't come from a randomised control. Well, it does come from a randomised control trial, but it also comes from unobserved analysis of 90% of all schools in Finland where this has worked. So it's not always about randomised control trials, but they play a very, very important role as well. So there are other sources of evidence there as well. But yes, we can demonstrate and we can look at longer term impacts, longer term outcomes. Sorry, I've forgotten the first part of the question now after that. So.
Leon, can I just comment? It's a great question. I think it's why it's really important to distinguish different sorts of benefit and different sorts of costed benefit. It really matters whether you're thinking about a fiscal return to the Treasury from a social benefit, which is different from an economic benefit. There might be benefits for firms and communities that will benefit Treasury ultimately, but are not going to lead to any money going back into the Treasury now. The reason we focused on the costs of late intervention, so the 17 billion I talked about before, that is money that the Treasury, through different agencies, it might be local government, DWP, Department of Health, police and others, is spending now. And it's only by targeting services on the threshold of those activities, so where children are at risk of passing over the threshold to drive the cost, that you're going to get close to having the chance to generate any element of that saving. Now, very often it won't be cashable because those services are rationed, so you might create a benefit for the NHS that means somebody else can now get a service that otherwise they wouldn't have got. It doesn't come back to Treasury unless you're closing a hospital or something. But there are examples within that range of services. We looked at 16 thresholds where by targeting activity for children and families who are close to the need that is going to trigger the acute or statutory intervention, that you can deliver the capacity to generate the fiscal saving. And that's where I think real action is required, because I hear a lot of places talking about early intervention to generate those services, but they're not targeting the services towards those people who otherwise are at risk of tipping over into need.
Do you think there are programs that are closer to the threshold for generating some kind of cash flow savings, that, as it were, the sort of the gold dust that we're looking for, of things that effectively pay for themselves?
I do. I mean, I think it's difficult for a number of reasons.
Yeah.
The point was made about the length of time involved. So particularly where you're working in early years, you might be waiting 15, 20 years, and it's very hard to know where exactly that benefit will fall. So that is, to my mind, an argument about why government funding is needed, because it doesn't sit with any single agency. It's a collective economic benefit. But I think there are programs now across the piece. I mean, David was talking about mental health and other, but every terrain of human development, people are working away on interventions at different levels of need. So for children who've experienced severe maltreatment, for children who have maybe experienced much less severe issues of neglect, but maybe are having certain developmental milestones not met, a whole range of speech and language and mental health services across the country, very, very skilled, that people have. The issues are not whether those activities can be made to be effective, it's whether they can be lined up in such a way that people are getting a high quality experience that is going to generate a saving ultimately. And whether that saving happens or not, I have to say, is much more about how government is structured and where the benefit actually falls than it is about the quality of the provision. That's just the distinction I want to make, that very often people are delivering high quality services. You still won't get a cashable benefit because, you hear about this a lot, certain towns where people are doing very, very good work for children at the edge of care, they improve and they leave and they go somewhere else. Well, it's why you need, it's a social problem rather than the effectiveness of the intervention.
Can I add to that? Just to emphasise again that the point about the time to benefit is really important when we think about this. One example where I think there are genuine cashable savings in a sense is violence prevention. Now, we know that issues in early childhood do increase the risk both of being a victim of violence and indeed being a perpetrator of violence, and that is something that can potentially be avoided, the costs associated with violence itself. Another thing I just wanted to, one very brief example, very quick. It's not necessarily the best example, but I like it because it looks across sectors. There's a programme in Canada called Better Beginnings, Better Futures, which has run for more than 10 years. It's an education and health intervention targeted at vulnerable children in Ontario. And what they've done there is they've followed the children over time, and they've identified benefits in terms of the physical and mental health of the children, but they've also identified benefits to the parents. They've identified benefits to the teachers in the schools where these children go. They've identified benefits to the education system because there are lower costs. Fewer children go to special educational needs. There's a cost avoided there. Special educational needs are incredibly expensive. And there's also reductions in costs in terms of what they call their social welfare, sort of social care, social work type system over there. And you can see these benefits. And what they've produced is a very nice cost-benefit analysis which shows that over this, I think it was a 7 or 8 year time period, there was a positive return on investment in terms of savings, but it certainly wasn't going to the health sector, it was going to the education sector and the social welfare sector. So it's bearing in mind that time issue and also the fact that different sectors will benefit and different sectors often will have to pay.
I think also there's a kind of English contextual consideration, I think, which is, of course, we've got an additional 1.4 billion invested in the system, but by the NHS's own admission, by 2020-2021, the NHS will only meet 1 in 3 children and young people with a diagnosable mental health need. So actually, from an economic investment point of view, it is best for us to think about what we do with the 2 in 3 children and young people whose through failure demand and lack of investment will end up elsewhere. And they'll end up at high cost elsewhere. So I think if we're starting to think about prioritising investment, I think investing in sub and pre-clinical levels of need so that they don't become an NHS caseload.
So as a public health approach, rather than relying entirely on treatment once the problem is there?
Yeah, a preventative approach, but also thinking about actually if the NHS is having to gear up to meet 3 in 3 needs and it's only doing 1 in 3 by 2021, actually how do we reduce what that overall caseload is in the future so that we don't need another 1.4 billion or 3.4 billion or 10.4 billion settlement to meet it?
And so a good place to look to identify that need is amongst children who've experienced abuse and neglect, because we know that 8 in 10 of those children are at a very high risk of having a serious mental health problem by the time they're 18. So the odds are very poor for them. Yeah. So if we target help in that direction, we'd be doing a good job at finding the 2 and 3.
Can I ask, Kate, do you know whether in Alberta they're doing work on the return on investment, the economics of it?
Yeah.
Is that part of the programme? Sorry, Nick.
No, I think I'm finished.
Okay, so who's next? Who's doing 10? Is it Bill? Thank you, Bill.
It's on delivery mechanisms, and what challenges confront those aiming to deliver early intervention or help? What's the key challenge? And bear in mind, we did say there could be a range of agencies. I think we touched on nurses, teachers, police, and clearly social services. What's the biggest challenge that they face?
I can give you 3 quickly.
Happy at 3.
We talked about service structures, the complexities of the service structures, the range of agencies involved, and therefore how in every place in the country you've got a different configuration of services that will be involved. It's very hard for people always to find their way through that very complex system. So one is the complexity of the service structure. Second thing, this is Science and Technology Committee, data. I continue to be really shocked at how little we know about the pathways of children through our services. It is, I'm told sometimes I overstate it. Maybe I'm just very ambitious.
Feel free.
But we ought to know. We ought to know how many children are in the securest state in government at any point in time and how they are, because they're very likely to go on to need other services. We don't know. Yeah. And that's an easy one. I could give you a lot of other examples. So children in care, levels of mental health support from CAMS of children in care, there's no routine data on that. So never mind the actual levels of mental health needs. So strategically, in order to be able to rationally target services, we don't have the data and information, and that feeds through to the front line because people are making decisions on the basis of inadequate data. So data is something, again, that politicians can do something about. And then lastly, if I may, political leadership. As I say, I've been around this 20 years or so, and I'm constantly told, can you make the case? Why can't you make the business case? And I'm saying it's not really about the business case. We know enough to be able to say that. We can't say every bit of early intervention will work, but we know the principles, and if we can innovate and support innovation and testing and learning, we will make this all much, much better. And what we need is people who are prepared to stand up for the idea of innovation in this field of the testing and learning.
And you did mention earlier that you had worked with various governments, and I did note that, and I sense with that statement that whilst you work with various governments, the progress has been
very slow.
No. Thank you. Sorry.
Can I add to that? I think there's also a very important role to be played by local governments, because we're talking about, from a public health point of view, that's a local government responsibility, and there are great challenges in working across sectors at a local level. I can anecdotally think of examples of headmasters or headmistresses, or whatever the right term is, holding the budget for the school and having to make decisions about what they're doing in terms of school mental and physical health type issues, when they've got other things they could be prioritising as well. So I think, and this may sound a heretical thing to say, in order to encourage collaboration and better cooperation across sectors, perhaps sometimes, as well as looking at the impacts in terms of adverse childhood adversity and mental health and all the rest of it, it's actually looking at the benefits specifically to those other sectors that either have to deliver or fund the intervention. So it may be around educational related issues if it's in schools. It may be about violence if you're trying to get the police involved. It may be about the social work system if it's about very early years. So in a sense, it's going beyond the brief that's specifically around the benefits to children per se, but thinking about how we actually market this and recognise that there are benefits that go beyond those children. And not being ashamed about that, but recognising that's another way of trying to create this conditions in which to actually invest in these services.
I would say 3 forms of sharing are the biggest barriers that we encounter. One is sharing data.
That's the data that we have to establish, first of all.
But, yeah, we do have some, though.
Right,
we've got to share what we've got.
We can improve the data.
We'd be a heck of a lot further on if we at least shared what we have, because bringing it together, it tells you a lot more than it does by itself.
The key players you would share this between, who would be the key players?
Well, we've just set up a data sharing agreement in Blackpool between the council, the NHS Foundation Trust there, ourselves, the police. They're the main bodies. Secondly, sharing budgets. In Blackpool, again, we set up the Bank of Blackpool. to hold a pot of early intervention funding. And the third one is sharing language. If you're talking about early intervention, you might have the health visitor, for example, that world talking about reciprocal relationships with parents and babies, and then you've got social workers talking about back and forth, and no one having a shared language about what we're trying to achieve together has proved very important in our work in Blackpool.
Just a supplementary, would you agree that when the contact's made with the parent or parents, a consistent person? And you hear a lot of reports, you read reports, it's a rotation of people. It's somebody this day, somebody the next day. Should there be a constant when you're doing that engagement?
I mean, consistent relationships are incredibly important, but failing that, consistent language helps.
And all of the evidence does show that irrespective of the intervention, the quality of the relationship is key to the success of any intervention. Yeah. What I was going to say is I totally agree with, obviously, the other three people on the panel, and I think there is something about how we incentivise local leaders, both political and commissioners, and people with strategic oversight to think about how to make this a priority in their area. The NSPCC has done some great analysis for a number of years of local transformation plans. We've got a forthcoming analysis of STPs coming out, sustainability and transformation plans, and both show that actually there is a lack of ambition, a lack of local coordination in thinking about how to intervene on an interagency level, how to just get the principles of adversity and trauma-informed care throughout the workforce, and then also thinking about how you create a commissioning model that allows for greater flexibility and return in terms of benefits across the system so that people don't become siloed and also territorial.
Can I just take it a stage further on training? I think it was Kate that made the comment, instead of asking the individual or the child, they tend to say, what's wrong with you? And you suggested you ask the question, what's happened to you? Yeah. To me, that strikes me as a training need and use of language. How should we train those who are tasked with identifying the person or persons needing the early interventions, and how do you take that, having identified it, how do you train those in the delivery of that help, as you say, or intervention?
Yeah. I mean, just to bring it back to the ACES agenda, it's a pretty good place to start in terms of those 10 questions. They do tell you something is not right here.
Yeah.
So it
identifies a need.
Yeah, it identifies a need for a conversation about what's happening here. It doesn't necessarily tell you that there's a problem that needs a statutory intervention, but it tells you that something's not right and how it might be needed.
And even further, NHS in Scotland, in terms of the national strategy, has embedded childhood adversity and trauma as a core public mental health priority. As a consequence, the body that's responsible for training in the NHS in Scotland has ensured that both low and high-level trauma-informed care is embedded in all of its training model. Now, that's also starting to happen because of the good work that Professor Bellis is doing in Wales. Yep. England is way behind that. I mean, we are just starting to...
If you were giving advice to this inquiry and this committee, that's something that you would be saying, that there's quite a lot we can learn from Scotland.
I'd say Scotland and Wales aren't perfect, but their national leadership on the issue and also their want for local ambition to address it on a population and individual level is the kind of ambition that we need to see coming through to England as well.
Just beginning to evolve in England, a bit behind. I think the final one, and it's a simple question: is the Early Intervention Foundation performing a useful role?
It was very well set up.
That's a good start.
Since they found better people to carry it forward, and I think they're doing a fabulous job. I think there is a slight, the challenge is that the range of issues on which they need to weigh the evidence is enormous, and they are a very small organisation. So I wouldn't claim, though as an ex-member of staff, that it covers the waterfront. I think it has set out some very useful structure for thinking about how to weigh the evidence and for making the cost-benefit case more rigorous than it has been before. We have to be both sceptical and realistic. And the Early Intervention Foundation is that. And I think it's using that to try to make the case to support innovation that works with the grain of actual local services. But it's not the Education Endowment Fund. It can't then fund the hundreds of millions of pounds that are required to actually trial and test. It can only review the evidence that is there. And that's not the fault of the Early Intervention Foundation. I think it's a weakness in the system.
Phil, have you got a final question? You okay? Stephen?
Thank you. Yes, I'll try and keep mine as brief as possible. As I'm sure you're all aware, the government's, in an attempt to tackle some of these issues, has published its green paper on young people's mental health. What's your take on it? Good, the bad?
The whole green paper, or
well, particularly the bit around transforming children and young people's mental health.
So I think there's some obvious gaps. One is around the early years, so where actually there can be good quality early intervention. I think also there's a question about what happens in terms of expanding crisis care for children and young people, and this is particularly relevant for those who need to acquire practical skills in terms of self-soothing or managing emotional distress, but also those who perhaps have sub and preclinical levels of need who haven't yet been diagnosed. And there was a huge expenditure in adults crisis care which didn't really benefit children and young people under 18, and we've called for an expansion within the Green Paper in that consideration. There is a mention of childhood adversity and trauma, you may have spotted in the Green Paper, which we're delighted about. Does it carry the level of ambition of making it a national priority with a public health priority and commitment to coordinated commissioning across the board? No. Do we think it should be there? Yes. Given the fact that there are questions about the future of the Troubled Families programme, about the comprehensiveness of the mental health support teams that are proposed for schools in coordination with CAMS, actually, I think this is a quick win in terms of starting to bring together all system players and coalescing around emotional distress, pre-levels and clinical levels of need, and then really targeting specialist support where it should go in terms of specific adversity groups or for those with diagnosable mental health conditions. So that was a consolidated version.
Anyone want to
just add to that the very good thing about the Green Paper is the emphasis on working across sectors, and particularly between schools and health, and that is badly needed. So that's a very welcome focus.
Okay. And the direction we think is spot on, but I would describe it as meek overall. So some of the proposals are extremely modest in their scope and their scale. Testing a few things in a few years' time in a few places doesn't amount to a comprehensive response to the challenge we face.
Okay. Would you care to give a reason why you think the government is being as timid as it is in its Green Paper? Why is it not being more ambitious? If you're going to do something, why not do it fully?
Well, because of the spending round, if nothing else.
It's purely money.
The 5-year forward view takes us up to 2021. Why would you make commitments beyond that time? In fact, the scope of the pilots in schools take us up to that period. There is a serious conversation that needs to take place about the settlement for children's mental health across the board, and then thinking about a coordinated strategy taking that forward. So I think this does actually build on the really positive steps of Future in mind. It does take us further forward. I think we should celebrate this as a huge success. But actually, is it comprehensive in scope? Are there gaps? It's not comprehensive and there are gaps.
Okay. Okay.
Yeah, and if anyone tries to suggest it's due to a lack of evidence about what we ought to be doing, I think that doesn't stand up.
Okay. Thank you for
it's
that.
Not that.
That's very, very clear. I mean, the purpose of these inquiries is we take evidence and we make recommendations specifically to government. What would you like us to be recommending? This is your chance.
Mine's probably the easiest, which is this should be a national public mental health priority translated down to a local level with directors of public health taking lead responsibility for this, but it being kept within LTP and STP planning, and there being a coordinated response. Alongside that, a robust programme of workforce development for all children's and young people's workforces, so that actually they can do the practical interventions that stop this being an expensive intervention down the line. That's it.
Thank you.
Succinct, thank you.
Yeah. Anyone else? Yes, David.
Yeah, I think it would be great if governments can think about ways in which it can help facilitate or encourage or allow different sectors to work together. And by this I mean, for instance, creating the conditions to allow pooling of budgets, the sharing of staff, the co-location of resources and services, because that can make a difference and government can nudge that.
Okay. Thank you.
So I agree with that. The Early Intervention Foundation, I told you about the 17 billion. We recognise some of that need is never going to be eradicated. It's inherent to the human condition. Our view was, well, we could easily aim to take out 10% of that. Probably, based on what we know about human development, maybe 30 to 40% of it might be a reasonable ambition that is avoidable and preventable. Yeah. But let's start with 10%. So we're talking about roughly £1.7 billion. And I absolutely agree that if central government could do more to incentivise the pooling of activity at local government. So we had the early intervention grant. It was removed, but it wasn't ever tied to evaluation of impact. So what we need is funds that are matched. So different local agencies pooling together, getting the support from central government for that work, and then making sure that there is proper testing and learning, allowing for innovation. And my key sort of ask really is, particularly as a Science and Technology Committee, you recognise the need for innovation, that it's not that everything needs to test and work, because that's the problem. People are too scared to test and fail, but then learn about what works.
Okay, thank you.
Very quickly, again, looking to Canada, there's something called the Innovation Fund, developed by Public Health Canada, which provides funding both for testing, if the testing works, for rolling out a bit more, and then there's a third level of funding for implementation. So the committee might want to look at their model.
Thank you. Things from Canada.
Sorry.
Good afternoon.
And Kate, would you like the final word?
Yeah, just to focus on one particular thing, which is to say to incentivise the development of trauma-informed services. So in particular in CAMS, shifting to a needs-based model could be transformational. And within that, to incentivise local areas to take into account the needs of abused children when they're thinking about their local transformation plans. Okay. In the last round, 30% didn't even mention services for that population, and given the high need in that population, it's indefensible.
Okay. Thank you very much. Thank you, John.
Just finally from me, one specific question for David. There are other mechanisms to bring in money to services, the idea of the social impact bond and so forth, and paying by the results that you deliver. Is the scope for that sort of approach? Are there any good examples of it actually working in practice? I know it was recommended in Graham Allen's report as one option that could be considered. What's emerging on that front?
Well, there are examples of effective use of social impact bonds in other areas. I don't know this area as well, but for instance around dealing with issues of old age, where it is starting to work. The one thing I would say, though, it's crucial to get the measure that the contract in terms of how one gets paid, deciding what that key indicator is very important, and getting the right indicator, one that can be delivered and one that's measured.
And is a problem with the sort of payment by results that often the results are so far ahead that it's difficult to persuade investors, social investors, of the case for it?
It is, and it's also that it can be sometimes a very it's missing out on some of the other benefits that are also being achieved by focusing on a specific narrow PBR type approach. So, but there is a place for it, and it does encourage innovation.
Kate, were you going to say something?
Well, I wanted to, just in relation to the question about before what we'd want to see, I wanted just to echo Professor McCrory's call for a National Council, Scientific Advisory Council on Early Child Development, not least so that we don't have to have this unfortunate squabbling, which actually obfuscates the areas of agreement that do exist, as Professor McCrory demonstrated at the end, and what the National Council in the States has done has elevated what everyone can agree on, and so people stop squabbling around the edges.
And can I conclude, is it fair to conclude from the evidence that you've all given, that you're all actually agreed that there is a need for something significant to happen at a national level, for it to be prioritised, as Mark was indicating, for there to be some sort of centre, multidisciplinary centre of this sort, and for it to be translated into local action in the way that is happening in Alberta and perhaps in Blackpool and so forth. Is that a fair summary that this is the sort of thing that needs to happen and is not happening at the moment?
Well, my point is that we need better funding structures, not necessarily more money, but the money needs to be better spent, and we need political leadership. I'm not at all convinced a centre, multidisciplinary centre in the American model is any kind of answer to the British problem, but so I wasn't sure whether that was...
Well, that's one element that was mentioned by
I think the need
Professor
for,
McCrory, but focusing more on the sort of national priority that Mark mentioned and the need to translate it into local action, as appears to be happening in Alberta. We've heard reference to the Blackpool example as well.
When there's either in Scotland or Wales or in areas of England where there's local or national or regional leadership, then what follows for that is good evidence, good intervention and good local leadership. So I think if we take that as a principle, yes, having the same form of leadership taken at a national level in England would spur on progress in this area and build the areas of agreement and consensus that can be reached quite easily.
So I think exactly what you said, plus the political leadership.
Thank you. David?
Yep. Just also the issue of linking data sets better and having that kind of infrastructure.
Of course, understand. Thank you all very much indeed. Appreciate your patience and the time you spent with us. Order, order.
Meeting has ended. The proceeding has ended.